Luann, if you would take the official attendance, we'll go ahead and get started.
Dr. Bobato,
Present.
Dr. Blader. I see you. Dr. Borges. I thought I saw, okay. Dr. Bryant,
Present.
Danette Castle,
Here.
Dr. Chapa, Dr. Farmer,
Present.
Sonia Gaines, Dr. Goodman, Dr. Harper, Dr. Ibrahim,
Present.
Dr. Miller, Dr. Lakey,
Present.
Dr. Liberzon, Dr. Martin, Dr. Martinez,
Present.
Dr. Mayer,
Sorry,
You're here.
Elizabeth Mayer, present.
okay, Dr. Mitchell,
I am present.
Dr. Nemiroff,
Present.
Dr. Newport,
Here.
Brittany Nichols, Michael Petriarca, Dr. Pliska,
Here.
Dr. Podewelt,
Here.
Dr. Robert, Scott Schlacklin,
I am here.
Dr. Suarez,
Here.
Dr. Taminga,
Here.
Dr. Ton, Dr. Thompson, Dr. Vo,
Here.
Dr. Wagner, Dr. Wakefield,
Here.
Dr. Wesley,
Present.
Dr. Williams.
We're here, back to school alphabetical.
Thank you.
Luann, this is Shannon Gingerty. I'm going to be on just for a little bit, and Dr. Keller will be on in just a little bit as well.
Okay, thank you.
So Luann, are we at quorum? All right, very good. Again, thank you all for taking time out of your busy schedule to be here today. We have a full agenda to update you on the progress of the old activities of the consortium, but also update you on the new activities we've been building out following the funds from ARPA. Again, a lot of work has taken place over the last many months, and actually the last several years, to put these projects into place. So again, thank you for your ongoing support of these really important programs. With that, we have a couple of introductions for our staff. With the ARPA funds, we were able to hire some key individuals that will help us make sure that we move these projects forward appropriately. And Luann, you want to make those introductions?
Yes, I am very happy today to introduce 3 new staff that we have to help us with the consortium. We have Jonathan Lewis, who is our financial and contracts manager. We have Sarah McLaughlin, who is a project manager. And we have Monet Thomas, who many of you have already heard from via email. And she's the project support specialist for us. So I'm very happy to welcome all of them. Oh, and also I forgot Laura, who is going to be helping us with our communications.
All right.
So welcome.
Very good. Welcome. It's great to have you here. With that, first item of business is the approval of the minutes from the last meeting. And Luann, it sounds like they were sent out and they're attached to the calendar announcement. And so
Yes.
if people would take a second and take a look at those minutes. And then after you've done that, we'll take the motion to approve.
Move to approve.
Second.
Second.
Second from Carol. Any further discussion? Seeing none, all in favor of approving the minutes, signify by saying aye.
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 Opposed, nay. Right, we have unanimous approval of the minutes. let's move on then to item 3, and we're going to get several updates from key components of the consortium's work. A lot of work that's been taking place, the new projects that we've started. And with that, first we're going to start with an update on communications and outreach and engagement, the work that the University of Texas at Austin has been doing. And Melanie Susswine is here with us via Zoom today. And Melanie, I'm going to turn the virtual podium over to you. Thanks.
Hi, thank you. Good morning, everybody. Nagla is going to run the slides for me. So I'm just waiting for those, but I'm excited to be here and update you all. Can anyone see the slides? I can't, and I want to make sure it's, no, okay.
They're not up quite yet.
Okay, cool. There we go. Thank you, Nagla. It is just a different presentation than mine, but it's working, so that's awesome. I can take a minute while Nagla is getting that ready to just talk about our social media. And I have a call to action for everybody here, just to make sure that you are following and that your organizations are following the KOSH social media accounts for CPAN, Facebook, Instagram, and LinkedIn. The way that we can grow our outreach and awareness is by more followers and then followers sharing those. So if you can take a moment and look up those accounts and go ahead and follow those and start sharing. There's some beautiful posts that they're doing. So I just want to encourage that. Okay, now we have it. So thank you, Nagla. We can go ahead to the next slide. Just briefly, what I'm going to do today is provide you with an update. We're focusing our efforts right now on CPAN, and then I'll leave time for any Q&A that you might have. Next slide. Just as a grounding, I have 2 slides in here about the Center for Health Communication and our process, so that we keep front and center that the communication that we are pushing out and the outreach that we're pushing out is based in research. Then we create insights, strategies, messages, and move forward with the tactics. When I was here last time, I spent most of the time speaking about our research and insights, and we have moved forward with the strategy and tactics. This next slide is just our logic model. I like to put that in each of our slide decks, again, to ground us on the research and what we should be doing. We check this at CHC frequently to make sure that what we're doing aligns, and it's just here for your reference. I did go over it last time in quite some detail, so I just keep it there for you all to have. This next slide really is where we start to talk more about the strategies that we have implemented. We have done some work around outreach and our media outreach as well. So our next slide starts with, again, our timeline. And we started in the fall and winter with those research pieces, and now we've moved forward. And what I'm going to talk to you today, the next slides, have to do with the spring and summer pieces. One of our first areas that we talk about performing in is paid search and outreach. So the paid search and outreach that we have been doing for the last 3 months is around social media SEO, so search engine optimization. You can see here on the left what an ad looks like, where it says Texas CPAN, local psychiatrist available, patient and referral support. Again, if we go back to our logic model and the research, one of the things that we heard loudly, you don't have to go back, Nagla, it was just me talking, thanks, is that the resources as a majority of our calls and a huge benefit to the providers and their offices. So we want to keep that front and center as a motivating for them. So that is an example of one of the ads that we have run over the last several months. You can see the performance, the clicks. We've had over 1,300 clicks on our ad. The ad has been served. So that means when we're thinking about raising awareness and we start with awareness building, over 32,000 people have had impressions of our ads. Our click-through rate is 4.1%, which is good, very good. Some articles put the industry standard in social media and Instagram at around 1.5%. So we're doing very well. And the cost is about $1,500. We're spending $500 a month on this. So the performance has been, I'm very pleased with our performance. I have some definitions on the bottom of this slide for people to better understand it. And I'll have Q&A at the end if anyone has a specific question. Our next tactic and strategy that we're moving into. What we've done so far in that previous ad was the social, the SEO around the AdWords that we've been buying. We are working and moving forward in the month of May, and I hope that it really starts more in June, where we will be doing digital advertising or digital outreach, where we are having outreach information served up on people's social media where they are. So in the first thing, it's people looking for information, and that ad is the social media ad is served up. But now we're talking about, if you remember when you if your own search pattern, sometimes you see an advertisement right before you are about to do a behavior online. So what we're doing is we're going to put that outreach and awareness piece right out there for people. And that will be starting in June. And again, you can see with this funnel, our goal is to really increase the awareness and get all the way to conversions, which for us means a provider calling CPAN, and then re-engagement is the utilization of CPAN. So they call back. That's our ultimate goal. And our next slide. Another tactic and strategy that we're working on is the video. We are in script development right now. We are working very hard to create something that is catchy and that is research-based for drawing in providers. So right now we're going back and forth in script development, and that hopefully at our next meeting, I'll be able to give you something to see around the video. We are also on our next slide, continuing to do outreach support with the HRIs. At this point, myself and very frequently our outreach consultant are conducting one-on-one meetings with HRIs where we're going through their self-assessment. That was part of the communication plan, and having brainstorming sessions with them about fine-tuning their outreach. I think that these meetings have been very, very productive. The feedback I've gotten is that it's valuable for the HRIs. We've conducted 10 of those. We had an all-day in-person outreach strategy session at one of the HRIs. We have 2 additional visits planned. What we're doing in those meetings is helping them put strategy into action around the different tactics that are in the outreach plan, such as relationship building, creating very targeted messages for their providers, helping set goals and measurements so that there's something that they can watch out for and try to achieve in this month, and having general brainstorming sessions as well. After the meetings, the HRIs are frequently reaching out to us to help them with fine tuning an email, perhaps with the clinic that they've been trying to get on board and wanted some support with that. We've helped them by helping them write articles for local publications. We've helped them by creating a list of community events in their area that are specific to office managers, so we can try to get into the offices. So we're doing very individualized support for them. Next slide. We are also working very hard to post, as I said at the beginning of the meeting, to provide Kosh with some social media graphics and posts 2 or 3 times a week on Instagram, Facebook, and LinkedIn, with the purpose of raising awareness and also positioning CPAN as the thought leader for pediatric clinicians around mental health. And that is why it is so important that all of you thought leaders in this meeting like and repost some of these ads. Next slide. The slides got out of order, Nagla. Can you go one forward and then we'll come back to this? Thanks. So we're also reviewing the social media that we put out to make sure that we're having a robust response to it. This is one ad that we did in the month of May, Social Mental Health Awareness Month. So this is actually one of the top 12 performing posts. And I pulled this last week, so I think it has even performed more. And what we can see from here is how many people liked it, how many people shared it, how much engagement we're getting. So we're doing evaluation of the posts to see what is resonating and what we can do to continue that engagement. Go back one slide now, Nagla. We also, in terms of the other strategies and tactics we're using, we're looking for ways that we can continue to raise awareness about CPAN. And during Mental Health Awareness Month, with the CPAN anniversary, we had a great opportunity. So some of the things that we did, you can see over here, there was very specific, social media content. And on May 20th, there will be very specific posts around that you all can view and share. We created some email content and an embedded email image that you see here. We also created this in Canva, so the HRIs could update it just a little bit for themselves to be able to share. And I've seen in some of their newsletters that they've done that. On the bottom, we created a banner for TPS that marks it. We've written an op-ed that has been co-signed by the Academy by TPS and also Family Physician Organization in Texas, and we are working on getting that placed right now. I pitched it to the Statesman on Thursday or Friday of last week, and I'm waiting to hear back and to nudge them as well. We also are raising awareness. CHC, the Center for Health Communication, sends out a prescription monitoring program email that has a lot of cross audience. So it's public health folks, and also anyone who can write a prescription can sign up for this email. So we added in the last month 2 mentions of CPAN and mental health for those providers. And then Dr. Williams on the 19th at noon will be conducting a webinar that the Michael and Susan Dell Healthy Living Foundation will be sponsoring and hosting. And they have about 14,000 people that went out to, again, raising awareness. Next slide. And that is what we've been up to. Questions? Yes, Dr. I can't see everybody. I'm sorry.
Dr.
Thank you.
Thank you, Melody. Really nice presentation. I really like your infographics. I think that's what it's called. It's really beautiful. I just have one quick question. How are you incorporating issues of health equity in your outreach and engagement?
I think that is a wonderful question. And we have spent a lot of time at CHC talking about health equity and engagement. So one of the ways that I in particular am trying to do that is through the individual outreach that I'm having with the HRIs, so that we can talk about what's happening within their service area and how we can outreach to different groups, and also when we create our messages in terms of the social media, you know, Dr. Vo, we look at literacy and we look at where our ads are served, and we're doing Instagram, Facebook, and LinkedIn. And I don't know beyond that for the social media, other than the way that we are creating everything to make sure that it is visibly attractive and it gets to the provider. Our target audience are the providers, and we have tried to look at FQHCs and those groups to engage. So that's what I have done. I'm very open to other suggestions. And does that answer your question? I've lost you, so I can't see you, which is a little hard to respond to a question and not be able to see the person. So I can't tell if that answered your question. And if you have any other suggestions, I am very happy.
Well, I think, you know, when I think about health equity, it's not just the medium in which you're targeting your audience, but also the message.
Mhm.
To reach certain vulnerable groups who may have mental health illnesses that are not being addressed. And so targeting providers who serve that population to be more engaged with CPAN would probably be a strategy. But of course, you have to identify who these providers are. So there's a multitude of different things you could do, and be more than happy to sit with you and talk about some strategies.
Yes, we would like that. And someone put in the chat about geo-targeting, and when we move in June, that is something that we are absolutely looking at doing for our social media, to be able to look at rural areas. And we've had discussions at looking at the areas that are low performing or low, I don't want to say performing, that are receiving fewer calls, and looking at if we can put more into those areas. Someone asked me last meeting if the strategy of creating a statewide outreach program versus being very specific and targeted to the individual HRIs. And my response was that we want to do both. And by being able to geo-target specific areas, it's one of our ways to be able to do both, that we will be offering these ads statewide, but doing more in those regions. And we were thinking of doing it in 4 regions. But I would love, we would welcome additional conversation, and I will follow up with you to be able to do that. Absolutely, we want to make sure that we're doing that. Any other questions or comments? All right, then I will thank
We
Malcolm.
we have one more question from Dr. Chapa.
Actually, I don't have a question. I just wanted to make a comment that Melanie actually did meet with us this last month. And just to again emphasize what she was saying, that it was a very good meeting. It was productive. And I believe that some of the concerns raised by Dr. Bo were also addressed in our meeting at that point in time, so that I can see like what you're saying. I mean, not to say that we don't have a lot more work to do, and it's important to continue to keep the focus on, you know, how are we best going to get to the community that needs our services. But I think just the work that you have done and done with us last month, I think has been helpful and shows that it's a good start, at least in being able to continue to address that. And our team has felt like it was very helpful when you came and visited with them. So thank you.
Thank you. I'm happy to hear that.
All right, very good. Well, thank you, Melanie. I really appreciate the work that you're doing. So thank you very much. We have several people that have come in since we did our formal roll call. And so want to recognize Dr. Liberzon here in this room. Thank you. And if you have joined since we did our roll call, if you would recognize yourself at this time, just so we have, and I'm talking about the executive committee members, and so we can make sure we have a accurate reflection of the executive committee members that are here today.
This is Andy Harper. I'm here.
Very good.
Sonia Gaines, I'm here.
Very good. Thank you. And Dr. Chapa, I see you.
Yep, Diana Chapa, I'm here. Yes.
Any other executive committee members joined us since the roll call? All right. Very good. Let's go to the next presentation on program evaluation. And Dr. Lopez, I saw you a little bit ago. We'll turn over the podium to you.
Yes, hi. Thank you, everyone. I'm excited to be here today. We have in the materials that were shared with you a draft of a summary report for the 2020-2021 biennium that we'd like to review today. So I'm going to share my screen, but I wanted you to know it's there. Hoping Nagla can give me that capacity. So let me start, as we're waiting on that, with just a little bit of the purpose of this particular document. We are hoping, thank you, we are hoping to provide a brief, I will say, overview of some of the activities that have happened in the biennium. Of course, the legislative report is really the core document for doing that. So this report is really aiming to capture some of our metrics from the 2020 and 2021 biennium in a formal way as we look back historically about some of the things that have been accomplished and what has been done in particular in the second year of the biennium by the consortium. So I will review this briefly, but I want you to know that you have it. We do a brief introduction of the purpose of the consortium, the initiatives underneath it, and then an overview of the purpose of the report. Here we do some contextualization of kind of what has happened over the 2-year period, recognizing that initial year was really a development and growing year, and laying out then some of the timelines for the different programs, how they were stood up, you know, how you all received money and when that happened, and when some of the data systems were put in place that can help us capture the metrics that we're wanting to report. So really just providing some context. And we lay out in particular that we are focusing this on CPN, TCHAT, and CPWE, and specifically presenting data for state fiscal year 2021. We do have a little bit of data for fiscal year 2020, but really most of the programs were just getting started at that point at the very end of that fiscal year. So we really focused on 2021 since that is when all the programs were up and running. So we start off with some metrics on CPAN. And here are the program metrics that we have. Of course, these were defined early on in the initial LBB implementation plan. Let me see if I can get that a little bit higher. So the number of providers, primary care providers that were enrolled as of the end of August 2021, it's almost hard to think back that to that point, as well as the number of physicians, kind of a subgroup of those all providers. We've got our percentage of phone calls that were answered within 5 minutes, which was 99%. It's hard to do much better than that. And our number of CPAN consultation calls that occurred during that 2021 year, and the percentage of enrolled PCPs who were using consultation at least once, which was 19%. We also have the percentage of PCPs reporting satisfaction with CPAN consults, which was 99%, and the percentage of PCPs reporting their comfort with managing care after the consult, which was at 75%. And I'm going to pause after each initiative, I believe, just to see if there's any questions. But here is our cumulative number of CPAN consultation calls over the course of that fiscal year, really just showing the growth over time as all of the programs were ramping up, as well as some messages from some of our providers who called into the system that let us know kind of how they felt about having access to this service. So I'm going to pause for a second just in case anybody has any questions about CPAN before I move on to TChat. Yes, Dr. Martinez.
Morning, Molly. Good presentation so far. Just a quick question. Do we know the number, you gave the physicians was 4,854 and all providers 6,491. Of that number, probably more the physicians, do we know what kind of penetration that is into the identified market? Like what percentage of the overall do we want to achieve?
That is a very good question. We will know that this year. Each of the HRIs have lists that they have all received, and they are diligently reaching out to those lists to determine anybody on those lists who's not actually seeing individuals in care, pediatricians, et cetera. And so they are giving us good documentation on kind of the best possible list we can to do that. There will be some sort of validation of those lists. And then by the end of this fiscal year, we should be able to speak to the penetration rates.
Oh, excellent. Thank you, Molly.
Okay, not seeing any other questions, I'll move on to TChat. So here is our brief introduction to TChat and the program metrics. At the end of August, we had 218 districts with active MOUs with HRIs, which also represented 2,311 school campuses. That actually, when you look at the students enrolled in those campuses, in order to understand kind of the number of students who are able to access TChat care, so not the number who did, but the number who are able to, we were at a little bit more than 1.7 million students that were covered. When we look at the number of actual TChat services that were provided, that was 5,702 over the course of that fiscal year. And then the number of actual TChat encounters was 13,041. So 5,702 students, unique students, and 13,000 TChat encounters. When we look at what happened to the students as they were exiting care, 2,063 of those students were referred for ongoing services following TChat. And this is a graph demonstrating the proportion of all Texas students that were covered by TChat over each month to kind of illustrate the growth in that coverage over time. And so at the end of August, 35% of all Texas students were covered by TChat. So could have access if referred by their school system. And then at the bottom, we've got some messages from families and students who were able to access the services about their experience. So I'm going to pause again and see if you all have any questions on TCHAT. Okay, sounds good. Moving on to CPWE. Before I start sharing metrics, I want to share that this particular component of the report, we are awaiting a few more pieces of information. Some of you may be aware that some definitions around the age of young people and who qualifies as a child and who qualifies as adult was clarified. And so a few of our programs are having to reach back out and rerun some of that data to make sure we're being consistent across the definitions. So these are going to change a little bit, but we wanted to share them with you in the overall report. Okay, so we had 8.9 FTEs for academic and medical directors represented in CPWE in that second year, and 15.7 FTEs of psychiatry residents. In that work, those individuals, of course, service delivery was not the primary focus of CPWE, and we note that in the commentary, but we do want to track the number of individuals that they have served. So we have 2,824 unique individuals that were served over the course of fiscal year 21. And of those, they provided 7,115 unique visits. And 82% of those adults served were children. Again, we're looking to get a little bit of clarification on some of these, but they shouldn't change very much. And then at the bottom, we recognize the community partnerships that you all have established with community-based organizations where those training opportunities are happening. And each of those different providers is a part of that. Of course, that is continuing to grow. And so that is kind of the report. It's brief, but really just trying to capture some of those metrics and provide a little context around that. So I'm going to stop again and see if anybody has any additional questions.
Not a question, Molly, but again, I think it's a really nice report. It's easy to see. You can get the data very quickly from reading through it. And again, congratulations for everyone for all the work to make this report possible and the work from the teams and seeing all these individuals. I think one of the things that we talked through, Molly, beforehand was that, and you noted about it earlier, is that this is where we were as of last August. And so just being very clear, a lot of work has taken place since then, but this is the report related to where we had been as of last August of ramping up these programs. Danette, I see your hand.
Yes, thank you. So this report is really good. One of the things that I was looking for, and I hope that we're able to provide, is what's the cost relative to the actual services. So I think about the reporting that we have in our system that goes to the Legislative Budget Board, for example, where we're able to see what we were able to produce relative to the cost. And that is typically shown on the Legislative Budget Board report, including in the appropriations bill, an average amount or an average cost per service, however that service is getting defined. And so I'm hoping that we're going to be able to do that. It absolutely looks fabulous in terms of what has been accomplished, and the value is clear in looking at it. I'm wondering if we're going to be able to also look at the cost per service, however that service is defined.
So in this year's report, that is not a part of our plan. I think the recognition that much of the work that happened in this first biennium was establishing the programs, communicating about the opportunities, developing the relationships. But I think that's something that certainly should be discussed for subsequent reports. And I know in the external evaluation, they've also been tasked with gathering a lot of information about costs and the cost benefits.
So at this point, in terms of doing that or running that calculation, we would, because I know that I've got questions coming in around it. So would we just look at the expenditures in each program for the year and just run that calculation according to the services that are included in the report?
I think that that type of analysis would probably not provide much of a true picture of kind of how those funds were spent and in what way it was being used. So while people might do that, I don't think that it's going to provide a very good picture of kind of the value for the services that were provided. Dr. Vo, did you have a comment?
I want to say I agree with you, Dr. Lopez, because right now, as it's ramping up the expenditure to amount of actual encounters provided, particularly in TChat, will look really inflated and expensive. So perhaps you give it another year and show, more utilization as well as the number of lives covered. So instead of the actual services that's being provided, that's actually, it's the potential for covered lives. So it's a little bit more realistic of all the setup and implementation and outreach that has been taking place with all the schools. So, but if you actually provide the numbers of, you compare the average of expenditure for the total expenditure for TChat to the actual number of services provided, it's not going to be really indicative of the cost.
The one thing I would say, Danette, is I think that's an excellent question. And for those of us that have been around Austin for a while, fully understand that those questions will be asked of us as we testify in front of the legislature. We need to be prepared to say the number of people we served related to the funds that have come in. I think the challenge right now is that we're in a very early ramping up stage where there's a lot of training that's taken place. There's the number of trainees that are being educated through this, and so it's just a little bit hard in this ramping up period to have that return on investment calculation. And to that, I would say that we've had that conversation with the external evaluation, and they have people that are interested in doing some of that analysis, and so we're open to that analysis. We just need to be very clear related to this was ramping up in the midst of the pandemic, and the hiring of individuals and a variety of things make it very kind of difficult to make the exact analysis that you and I would like to have right now. But that's where we have to go. And we're going to need to be able to show the legislature the value proposition related to the number of people served, number of consults, trainees, et cetera, based on these investments, which is a large investment for the legislature. Does that make sense?
Yeah, thank you, Dr. Lakey. I do appreciate that. And I, we've actually had conversations even with legislative budget board staff over the years about getting to a place where there's a recognition in the reports that they produce to the covered lives aspect. Certainly when we're trying to provide access to care for indigent outpatient services, for example, the fact is that we are trying to ensure, and Dr. Lakey, as we try to move into a no waiting list kind of environment, ensuring that people can get access when they need it, that, we're in a circumstance in which that is a covered lives context. But we have yet to be able to get them to actually go there in terms of any of the calculations that they run. So we want to be part of expressing the value of these programs. They are augmenting service delivery in so many different ways. In many ways, much of this is what we dreamed could ever happen, and it's actually going on. And so we want to support that. But you're right, we do get those kind of questions in and around the Austin area, maybe specifically more so than in other areas of the state, but we want to be well prepared to respond in a way that is supportive.
Shannon, I think you had a question.
Thank you, Dr. Lakey. So I just want to echo that this information is extremely helpful, and especially the way you've displayed it. And I'm hopeful that we can use these documents in several conversations with the legislature. And to that end, no good deed goes unpunished. Dr. Lakey had mentioned that this data comes from where we were back in August. So my question is, when will we have something updated that's got, will you do this again will it take another year after this next August, or will we have something kind of going into the fall that we can use with the legislature that's the most recent numbers? Or how difficult is that to do?
I could speak to that. Alice. Should I go ahead?
Sure.
All right. The data management committee is, yeah, now we've hired a full-time data analyst. Actually, we probably should have introduced him here at this meeting if that slipped my mind. He is working with Lachelle, kind of starting to pull together the data, particularly for TChat and CPAN. We're getting pretty much up-to-date data every month, and we can actually start probably presenting that. I think it's, well, we want to take a look at it a few more meetings to be sure, you know, we agree with how it looks and there aren't any issues. The CPW data will take a little more time to get it in, whip it into shape. But Shannon, short answer to your question is yes, we should be, I think, the point where we could have a standing item on this committee of activity through the prior month should not be a heavy lift. I mean, Laurel, do you have any comment on that?
I guess my comment is similar to everybody else's. We have preliminary data. I think, Shannon, the thing that we're always cautious about is we wait for the evaluator team to make sure that they've checked that this is accurate before we send it to external. So I think that Dr. Pliska is correct that I think we're getting to that point where we'll have things that will be able to be more regularly timed out. Kosh presents to this group, every time, here's where things are preliminarily. So you do have a little bit of a snapshot into that, but the sort of it's been certified and checked is I think the step that we've all kind of been working through. And so that's the step that I think we are pretty close to getting there. That's my impression.
I think one dilemma is where CPAN was the one program that started out with a clear set of rules day one. And that makes that data very consistent and easy to follow. TChat and CPW were very decentralized or somewhat decentralized in terms of number of people involved, the exact way people set up their individual procedures. So that in turn has made gathering certain types of data more complex. Some data is very easy. How many people did you see in a month? Well, how many live bodies came in and had a visit? That we can calculate. How many people were referred versus how many people you saw? What's the definition of a referral? Some of these things we're working through, but I think I think we're almost there. And then we get into this second set of analyses. Well, which people are going to be very interested in. What's the cost effectiveness? What are long-term outcomes? We'll be able to go there next.
So Danette, I see your hand, but before I go to you, I guess, Shannon, what I would say is that this is an end of the year report, and we're going to finalize that end of the year report. But Michelle has just reminded me that, on our webpage, we're updating that data, and we'll have that available for anybody. I have a presentation next week to public education, and folks have updated the data for TChat. And so what Steve is saying is correct. That, at any point of time, we can give you the numbers. They need to be validated, et cetera, but we can give you pretty close numbers of the number of people seen. But that's one part of this communication strategy. And one part of those parts is today, hopefully approval of this document as final, so people can share that with legislators or with teams as we continue to update the data month by month as we see additional individuals. Does that make sense, Shannon?
It does. And so you'll be able to present up-to-date data at the House Public Ed Committee next week. Will you be able to present it in a way that we've kind of seen it in these graphics that's really digestible for the members?
Well, the good thing is that Molly sent me today an update version of the data. And so the same people that put together this report will be helping us present the data next week at public education. And so I've just briefly scanned through it because it was sent to me this morning, but it looks to me to be the same type of easy to understand metrics to communicate the work of the consortium. Molly, anything you want to say?
I hope it's digestible, and if it's not, we can we can definitely shift and make it so. Dr. Lakey, do we need a formal request? Because there's one more item under me that I'm going to have Dr. Pliska do, but I wasn't sure if we needed to wrap this one up.
Let's approve this report so that the members of the executive committee can share it. I wanted the executive committee to see it, approve it before it's sent to other individuals, out of respect of the work of the executive committee. And if everyone feels comfortable, we're going to approve this report, and then we'll put it on our website. We can share it with our stakeholders and move forward. And then we can go to the rest of the information on this on our agenda today. Any questions about this report? All right.
Dr. Lakey, not a question, but just a comment in terms of, so we'll take draft and it's in its final state when we publish it to the website.
Yes. All right. Anybody want to make a motion to approve this report?
I'll move to approve it.
Second.
Okay. I have a motion by Dr. Plitzka, a second by Dr. Nemiroff. Any further discussion? Hearing none, all in favor, signify by saying aye.
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 Opposed, nay? Anyone abstaining? Hearing none, the report is approved, and we will share the final document with folks and put it on our website. And again, thank you, Molly, for all the work and for you and your team for putting that together. The second item.
We have a.
What's that, Steve?
No, I think Molly has another item she's going to pass to me. We need to do that before we move on.
I have. Okay, we can do that, but I also have David Lynch, Molly, as part of your presentation to give a quick verbal report. You want to do David's first, or you want to move to Steve first?
I'm
not sure what David's doing. So maybe let's do Steve first and just make sure that we're not covering it twice.
Mine's the definition of a primary care, which needs a vote.
Okay,
that's what you're talking about, Molly,
I
right?
know David Lynch is by that, but Steve, I will go to you.
No, I think David's not here, so I believe that's been delegated to me.
Okay,
Right?
go ahead.
Okay, all right. I need to share my screen. I can just do it. Ah, good. All right. In CPAN, we want to look at the statistic, the degree of penetration among all the primary care providers in Texas. And as it's note here, that falls across several different disciplines. So what Kosh has been doing is getting a list of all the primary care providers, the MDs in Texas, and sending that out to the various HRIs in their regions to kind of scrub that list to make a denominator around the physicians. The original plan was to do the same thing with these other disciplines, clinical nurse specialist or physician assistant. Now, the difficulty that David and the internal team ran into is that, as I see it's very difficult. In fact, it's impossible to go through the list that the state boards have of advanced nurse practitioners or physician assistants and reliably say whether they are a primary care practitioner or not, because what they're doing is going to be determined by their physician supervisor as opposed to the degree that they hold or how they designate. They don't designate themselves in any state board database as I am a primary care nurse practitioner or physician assistants. And so the internal team says that, that since we're going to be any advanced nurse practitioner who is in primary care is going to be within a practice that's doing primary care, so that the number of primary care MDs should be a sufficient metric as the denominator. So basically what the internal team has proposed is what you see here in yellow, that basically we're going to delete from both the denominator and the numerator the number of nurse practitioners and physician assistants, so it balances. We're looking at the total number of possible MDs who are primary care practitioners, and then the numerator is the number of those MDs who enroll in CPAN. And proportionately, that number would be the same as if we could accurately get all the non-physician PCPs, numerator and denominator, but by eliminating them, we reduce the risk of having an enormous amount of inaccuracy. Because if we were to include a bunch of advanced practitioners who appear to be primary care providers, but in fact are not, we would dangerously inflate our denominator. So I'm basically making a motion to the executive committee that we approve this edit to CPAN metric 1. And I'll stop there and see if there are any questions or concerns.
Move to approve. Podolitz.
Okay. So we have a motion and a second, but Podolitz, we'll open it for discussion. And Dr. Liberzon, I see you have a question. Just push the.
Okay, it's more common than a question. And maybe I misunderstand it since I'm relatively new to Texas. Aren't all the nurses and PAs, when they're functioning, there is a signature authority to the MD that's supposed to be backing up?
That's correct.
Well, in this case, counting them separately is actually double counting. It's actually, in the first place, it was a silly idea, because if all the patients, we're not interested, we're interested to see how much it penetrates the primary care, not particular categories within a primary care. And if we include all the physicians, or as much as we can, physicians who are doing that, we basically cover them all, because all the patients of NPs and PAs are already covered by physicians.
That is essentially the reasoning that the data committee adopted in proposing this.
Okay, yeah, right. So I think it was just aberration at the beginning. I think I'm in full support of that.
Any other comments? Questions? Hearing none, all in favor of the recommendation by Dr. Pliska, signify by saying aye.
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 Opposed, nay. Anybody abstaining? All right. Thank you, Dr. Pliska. That is approved. Let's go to the next item, Dr. Peskin, related to the external evaluation of the consortium.
Great, and I was going to start us off. So, and then Dr. Peskin will pick up in the middle. We are presenting our year 1 findings at a very high level here. And as we go through it, want to let you know that we've done these analyses by HRI and aggregated. So if individual HRIs want to meet with us to get feedback on individual HRI information, we're happy to do that. But I'll take you through this and then hand it off to Melissa. So if you want to go to the next slide. So year 1, we focus a lot on the formative evaluation to understand what comprises implementation at each step, from HRIs, conducting outreach to build their networks for CPAN and TChat, to implementation within clinics and schools, and then front to the services piece at the HRI level again. And then ongoing process and outcome evaluation was conducted using the trait data, which we were cleaning as we aggregated data and compiled data across sites. And then we used our own surveys and formative work that Dr. Peskin will present. So if you go to the next slide, I'm going to just give you a quick picture of what the process mapping step comprised. And you can go to the next slide, and we just give you, I know this is hard to read, but each step we went through a process map for each HRI to understand the HRI process for enrolling clinics or schools, identifying clinics or schools, and then enrolling, and then the process within the site and what activities were used, resources, personnel. Each of these processes gave us an understanding of what comprised their core elements and activities and strategies used. And it helped us to understand what were common elements across sites and what were unique. And you can see that we color coded this so that we could map out strategies versus resources used. And if you go, so we identified, this is how we identified what we were going to monitor over time. So if we know that there are core elements here that they said they were going to use to implement the program, later in our surveys, we collect data on those core elements to see what fidelity to implementation looked like and what challenges may have occurred if these activities as planned didn't happen. So if you go to the next slide, I'm just going to summarize what happened after that. So we actually didn't include in this presentation, but we have tables where we, for each HRI, broke down what activities comprise their implementation. And we found what was in common and what was unique. That enables us to see what they may be able to share across sites as successes, and also may see some gaps. So across all 12 HRIs, for example, we interviewed clinics at the CPAN level and reported that they all reported receiving brochures or other information about CPAN during the enrollment process. 5 of the 12 clinics during these in-depth interviews to create the maps recalled the person being interviewed recalled receiving any training from the HRI. And then among the clinics that reported they did not receive training, 4 of them indicated that a training would have been helpful. So this is information we could follow up on in our survey data. So this was information we were gathering when we were conducting the process maps. So we learned also from these interviews a desire for more education about mental health topics. So this was more content related, not process related, but it emerged during these interviews. About half of clinics reported receiving information about the HRI through email or monthly newsletters. Among clinics not receiving information, a few, 3 mentioned that they would like to receive ongoing communication and education about mental health topics. And clinics indicated specific resources that would be helpful, including lists of type of therapies, community resources. So these are this is kind of information that emerged that we also were passing on. And we have this again by HRI if you want to reach out and go through individual process maps. It's really good learning activity to help improve what's going on. We know this is the first year, so this is a great opportunity to learn from this. The Project Echo could learn from what topics may be a good one to put on the list to cover in some of those trainings. So if you go to the next slide, for TChat, some of the key findings from the process mapping interviews as we synthesized and aggregated across. Several counselors, 7, were very pleased with the level of communication they received had with the HRI, and then some of them, 3, indicated that there is not much communication from the HRI after submitting referrals, and they wanted to have more of a status on students going through TChat. So, so that might be something to have a discussion about, what can be shared, what cannot be shared, expectations. Barriers to TChat, a few school districts, 5, mentioned that obtaining parental consent was their biggest barrier. Space was an issue for some schools since they had 1 private room for TChat sessions, and that was 3 schools. And 2 districts mentioned that they had challenges utilizing TChat for younger children since telehealth appointments were not as engaging for them. Again, this is a sample. This isn't, we didn't do, we had to take samples of clinics and schools. So these are the interviews that we had with a sample of HRIs, but we made sure to capture it for each HRI site. And so a summary of these for the process mapping, just again, to reiterate, the purpose was to understand what implementation processes looked like, what were the core elements that were similar, how they varied, looking at variations in outreach and engagement strategies and resources used across sites. Later, we'll be linking that to results to see if we can find some of the strategies that were importantly related to results and could help prioritize strategies to share across sites. The process mapping, another purpose was to serve as a baseline of strategies used across HRIs so that we can now monitor and continue to identify successful approaches related to implementation and outcomes. And several HRI leads expressed an interest in learning more about the processes used by other HRIs, so providing insight into the usefulness of the maps as a learning tool and leveraging findings across site. So that is a very quick overview of this step, and a lot of information was captured that might be helpful, and we hope to be able to share that if you want to reach out and learn more about your own sites and see what strategies or resources were and weren't being used and what might be tried. And if you want to go to the next slide, the next part of our evaluation focused on process and outcome evaluation using trait data and survey data. So if you want to go to the next step, this is from our trait data. And here you can just visualize, we were looking at reach. And so this is circle clinics that were enrolled in the network. And again, this is first year data. So this is as processes are being developed and the networks being built, these are actually the results that are emerging. So you can see because we see that your focus is reaching vulnerable, underserved areas and populations, we looked at this by a rural urban continuum designation. And if you can see this, the clinics on the outreach list are on this far right column. So the 8,024 were the lists that were used to focus enrollment. And you can see by metropolitan, non-metropolitan, and rural designations that there were a lot of the focus to get out of urban areas into non-metropolitan and rural. Rural is very rural in Texas. So depending on your designation of rural, I think that the non-metropolitan designation also is probably picking up on some of this rural status. But you can see that there was a really good job at reaching these harder to reach in terms of not right directly in the metropolitan area. And so the percentages you can see in the comparison in the table and just a visualization here. And if the social marketing team is geo-targeting, these maps might actually be helpful in seeing what areas are not being reached in terms of enrollment of clinics. And then we blew up the metropolitan areas just to see more at a more local level. You can see the outreach and they are dispersed throughout those metropolitan areas as well. If you go to the next slide, we also did this for the SVI, which is the social vulnerability index. And this is an index composite of indicators of vulnerability that CDC has. And you can see in this footnote, it's hard to read, but the data source again is the provider list, and in Texas purchased from the Texas Medical Board by Kosh. So that was the clinics by providers on outreach list here, and then the CPAN enrolled clinics. And so you can see that, again, it's a really good distribution of vulnerability in terms of especially the most vulnerable being reached in enrollment. So that seemed to be aligning with goals in terms of these enrolling clinics that were serving more vulnerable populations. Again, you can do the comparison by the percentages and just visually, you can see it here. And we'll continue to refine this. We're working with a spatial analyst that is helping us do more targeted analysis and with these metrics. So if you go to the next slide, you can see that from the survey, I'm going to pass it on to Melissa so she can actually walk you through the survey. One thing I just wanted to also say, we both wanted to share that this is year one data that we're giving you results on. We are doing the same. We have the same approach. We're not doing process mapping again, but we're really right now have been analyzing the reach and the served. There's a lot of served data that we've been that we include in our external evaluation year one report, and we're actually about to pull together our results right now that we've been working on for this for 6 months of year two. So you should have more data on that from us coming soon.
Thanks, Laura. So I'll now just do a quick overview of our surveys that we distributed to providers and school district personnel. So again, this was during year one. And so this survey was administered last summer to approximately 236 providers across 86 clinics or clinic systems. And we really worked hard with consortium directors of enrolled clinics and providers to ensure the creation of a diverse sample of clinics with respect to SES, clinic size, and geographic region. And when we looked at the comparison of our sample to the comparison of clinics in trait data, we saw that our sample really did mirror the distribution of those clinics enrolled in trait with regards to those geographic and population level vulnerability indicators that Laura just talked about. And so you can just see on the side here, this was our flow chart in terms of how we actually recruited, how we actually got to our sample size of 236 provider surveys. Next slide. And so again, we'll just do a very, very high level overview. In our report, we have detailed tables that really outline all of these. But basically, one of the goals of our survey was to really look at factors that were associated with implementation. And so we were able to compare those clinics or clinic systems who reported at least one call compared to those who reported no calls. And what we found using constructs from a highly used implementation model framework is that clinics or clinic systems who reported at least one call reported more favorable CPAN motivation. So they felt that, CPAN had greater relative advantage, greater observability. They could really see the results in their practices. They also felt it was not very complex compared to those clinics or clinic systems who reported no calls. So in terms of outreach and trying to increase, usage of calls, trying to target some of these factors might help increase usage among those clinics that are not making calls. We also found that providers, similar to what Molly reported, vast majority of providers reported that their knowledge, skills, and competence to provide mental health care increased moderately or very much due to CPAN. Overwhelmingly, providers reported that they would recommend CPAN to other providers and to use CPAN in the next 6 months. And some most frequently mentioned areas of improvement included a desire for expanded services, improved outreach and awareness of CPAN in the community, additional communication options, more training, and improved connections to resources and referrals in the community. We also collected some qualitative data, and here you can just see on the right, you could see a word cloud of some of the most common words. But yeah, go to the next slide, Nazla, sorry. Just a few quotes that we thought sort of illustrated what we found. CPAN has allowed me to consult with a psychiatrist about more complex mental health patients. It has given me the confidence to start medications I otherwise would not have. Taking this survey, I now realize that CPAN provides many resources other than just consult with a psychiatrist. It'd be helpful to be aware of some of the other resources they provide. And then a comment about making sure the referral list that they get is up to date. So then I'll move now to TChat. The next slide. So we also did a survey with TChat school staff, and this was also done during year one, around this time last year. We surveyed 277 school staff across 172 school campuses.
And again, we work to ensure the creation of a diverse sample. And you can see on the right the flow chart of samples. And again, we didn't show the distribution of school districts in terms of metropolitan and non-metropolitan, but it really did, again, correspond with the trait data that we collected, with the exception of having a bit more overrepresentation of non-metro campuses in the actual survey data. So some high-level findings, if you go to the next slide, is that the vast majority of campuses who took the survey reported implementing TCHAT at some level, and this was expected because we did reach out to those campuses who actually were implementing TCHAT. Just in terms of understanding, some of the needs and the characteristics of the schools in which the services were provided, majority of those surveyed, majority of those who were implementing TCHAT reported that at least 25% of students in their campus had need of non-educational support, such as meals, clothing, and then counseling or behavioral therapy needs. School staff reported that TCHAT increased school capacity to meet non-educational needs of students. Similar to CPAN, very high satisfaction with TCHAT in terms of recommending it, but then also some areas of improvement, including the desire for better communication and follow-up, a more efficient system for paperwork, additional student sessions, more training on campus, marketing tools, and then implementation expansion to other campuses. And so just a few quotes that we thought sort of illustrated the findings. And we just got a ton of really rich qualitative data from the few questions that we asked about TCHAT, more than we actually expected to receive. The people were very responsive in terms of their answers. Can you go to the next slide? I would like to be communicated with about my students after every session to be aware of how I can support my students in the school setting. I wish we had more informational papers to hand out to our parents. I think we would have more participation if the information was widely available. And then TCHAT has been a blessing to our less fortunate families who are in need of mental health services. Being able to provide the service to our students has contributed tremendously with regards to better attendance, grades, and disciplines. And so that's a quick snapshot of our reports. We're happy to take any questions and share any additional information as requested.
Very good. Let's open it up for any questions, comments. All right, I'm not seeing any. So maybe Dr. Pliska, and again, Dr. Savas, thank you for this work. Next step, this analysis, how will it be shared? And besides this setting today, and what are some of the next steps that our institutions should anticipate?
So I think Dr. Savas mentioned that we'd be happy to share with the HRIs our individual process maps. And so we could start to put something like that together for each HRI as a packet with their specific results. So I think that's probably the next step on our list, if that's something that would be of interest to folks.
All right, very good. All right, thank you very much. And again, appreciate all the support and the evaluation that you guys are ongoing. With that, why don't we go now to number 4A, and we're going to have a concentrated time now to talk about ARPA and the standing up of the different ARPA projects. And with that, again, I want to welcome Linda Haster from UT Austin, who has been very helpful to us as we've been working through the financial component of ARPA. And again, Linda, it's great to have you here and look forward to hearing your presentation.
Thank you. I did not send my files to the team ahead of time, but I will next. But if I could share my screen, I will present. Sure, I don't have any problems. All right. Okay. All right. Just made there are very few slides. It's mainly just notes to kind of keep me focused on updates that I've made with each of the meetings that I've held with the HRIs that I will be overseeing with the fiscal piece of it. So I thought I'd first share with the group, the team that, the agenda, I guess I should share. So I want to introduce the team that we've selected that we're going to be using from UT Austin. So I'm the Associate Director for the sponsored programs that are run here at UT, but we selected 4 key individuals that will just focus on the ARPA to make it easier for the HRIs to navigate, considering that we have other relationships with them on other grant funding. So we thought it would be simple if we just made a core team. So I want to go over some of the pre-award notifications that we sent out, give the group a contract update, talk about some budget concerns that we had that were brought up when we met with each of the HRIs, and then the questions that they brought up related to the billing and reporting. So the team that's going to be operating for the oversight piece here at UT Austin is myself. I've also recruited Jory Hatch, which she'll be in contact with all the HRIs to take care of all the reporting needs and map it with any data that we need to with the programmatic piece if necessary. I realized one of the comments that came up with one of the other committee members was talking about how to align that data. And we anticipated that would be a request of us down the road. So we're already thinking in that same mindset, how we could do that for you. We're going to have Laura Ochoa, part of the team. She's going to be the person that you contact regarding contract changes, budget adjustments, and those type of award management issues. And then we've designated some administrative support, Rachel Holt, in order to expedite any subrecipient invoicing that comes our way. We want to make sure all of the HRIs are reimbursed in a timely manner. So we've dedicated a full-time resource just for that portion. On our end, it's a half FTE, but her whole focus will be ARPA related to the billing pieces of it, to be communicating with each of the HRIs and making sure that that flow through of money that has to go all the way through the pipeline is not delayed in any part by us. So I've included some contact information. Dr. Jaffe here will be listed as the primary principal investigator with all the contract negotiation, but my team would be the ones that would take care of the operational portions between all the HRIs. And so that'll be shared with each of the groups. I did recently send out back on April 22nd authorization to grant some pre-award spending so that each of the HRIs could begin to start posting positions. I know recruiting is going to be quite difficult already with the layers that have to do with COVID and resources. And so we didn't want continued delays with contracting to prohibit them to begin that process. We did authorize that to go back as far as January 1st, just in case some initial programming cost had already occurred, because each of us had thought that the contracting piece would come a little bit sooner than we had anticipated and what's actually happening. So for the time being, I've authorized only 25% of the budget, which in our minds represents about 6 months if you're looking at it for the 24 months of period of performance. We'll just monitor that percentage with each of the HRIs as we go, depending on how the contracting negotiation goes. So, but we thought initially that should be sufficient for each of them to start recruiting and posting positions at their institutions. Contract updates. So we've met with each of the HRIs at least once. We've had some group recurring meetings that we've established. And so we've had a full, our monthly engagement meeting as well. So we are moving forward with the assumption that we're all going to have a subrecipient relationship between each other. There were some concerns when we talked about the period of performance. They're all understanding that we're bound by the LBB and that the contract will end in November of 23. And so with the delayed start, there were concerns about would they be given the full 2 years to run the programs. We've shared with them that it's our desire to keep everybody abreast of the progress that we're making and that we're prepared to request a no-cost extension when that time comes. But for now, we're going to move forward with the end date as defined by the LBB, and we'll deal with the completion of the initiatives as we get closer to the second year. Feedback I got back from each of the HRIs, 6 of them would like to have one single contract with us that outlines the 3 initiatives that are mandated for them to operate through. And then 5 of the individuals have asked to have multiple contracts based on the 3 initiatives so that it's easier for reporting on their end. And I believe we're still waiting for responses from 1 of the HRIs. Let's see. Just a couple more slides. Some of the budget concerns that came up after meeting with each of the HRIs was related to Meadows, and so related to the pediatric collaborative care portion that they're going to be overseeing. And so they, because of the contracting terms being cost reimbursable, their fear was having to be responsible for that much of the budget and wait for reimbursement might impact their institution. So I'm going to be having discussions with each of the HRIs, the 9 partners that they designated to me, to see if we could adjust the contracting to include the portion of the budget that was related to the Meadows initiative, perhaps in their primary budget. So those discussions are taking place, and once we can come to terms and finalize that, we'll share back with the group and make sure that everybody's agreeable how that can work. The other piece is related to if we did that, we had not had a budget directly with the contracting with UNT Health Science Center, and that is one of the 9 HRI partners that they were going to want to be working with. So we do realize that we have to go back and make initial conversations with UNT as well. And so we're in the process of scheduling that introductory meeting and to talk about the concerns that Meadow brought up during their initial one-on-one with us. Billing and reporting was the final update that they were all, of course, concerned with. As I could see being part of the committee meeting today, a lot of the reporting is very detailed and transparent for the public. I do realize that they'll want also the financial pieces as well in that same manner. So each of the HRIs understand that we'll have more expanded conversations related to how we're going to tie that data. But we have expressed that all of the financial invoices and stuff that we receive need to be clearly identified and mapped to the different programs and initiatives, so that when it comes down to trying to map the reporting detail to the programmatic piece, it'd be easier on all of us as we go. So we've stated that from the very beginning, that they have an expectation that they're going to have to assist us with making that mapping take place. And the 3 initiatives that we were referring to are, of course, the according to the budget that was approved when we first were asked to be the fiscal agent. So that's what I have for the report today. I'm sure as we begin starting to receive invoicing and stuff, our intention is to be as transparent to tell you the burn rates and what we're seeing happening and how all the dollars relate to the program. So we'll have a little bit more information to share with you at the next meeting, I'm sure, as we get the contracting underway. Are there any questions from the group?
Very good. No, thank you, Linda, for all the support. And it's really, I think, a great partnership to be able to work with you guys as we move these dollars forward to our institutions and make sure that we do the accounting the way that we have to in order to be good stewards of these funds. Because all of us are aware with these federal dollars, we need to be very, very careful with them. So I saw a hand from Alex Vo. Alex, let me go to you.
Yeah, thank you very much. In one of your monthly meetings, Linda, there was a discussion that allows the HRI to move funds between the 3 programs as long as they don't exceed 10%. In your slide 6, for those HRIs that are electing the 5 that are electing separate contracts, how are you accounting for that between allowing them to move funds between contracts?
Yes, and so we will be keeping metrics on our side to make sure that we're adjusting for each of the HRIs and how the funding is going to be shifting around. And so when they're within an initiative, we've expressed how there's a lot of flexibility for that. As long as you're not taking dollars outside of one program to the other, it's going to be very easy for us to be able to make approvals for budget revisions. And so we've asked each of the HRIs that we're being notified as a courtesy for those internal shifts. It's only when you cross over from each of the three programs, which we have outlined it on the final slide, where we have to be a little bit more cautious because we may get 2 or 3 requests that keep us under the 10% threshold. And it may be that 4th or 5th request that we get from one of the HRIs that takes us over. We'll have to go through the process and formally request a budget transfer. And so we definitely will be transparent with everyone at each meeting on where we stand at that moment. So everybody kind of knows if your institution is thinking about making some shifts between the programs, you're already seeing what we've already granted internally that was below the 10% threshold.
Very good. Any other questions? Seeing none, thank you again, Linda, for the ongoing support of the work. We're going to now go to Dr. Wakefield, who will be discussing the work in one of the new programs that we're standing up, the pilot to establish a perinatal psychiatric access network here in Texas, PeriPan. And Dr. Wakefield, I'm going to turn the podium over to you.
All right, thank you so much. Can everyone see my presentation?
Yes, we can.
All right, great. Well, I'm excited to talk about PeriPan today. Just briefly, our agenda will cover many, many things, reminder of our reason, review of the PeriPan pilot sites, some national best practices and what we've learned so far. We spent a lot of time since the last meeting with different states and state initiatives as part of the Lifeline for Moms consortium. So we'll talk a little bit about that. Consideration of some language on the Lantana line prompt that we think will lead to less confusion with this pilot program. And then who the support team is for the project, phone and data product vendor discussions and updates, our launch plan, and then answer some questions. So again, some of this information we know very well. Perinatal mental health disorders are the leading cause of maternal morbidity and mortality. And what we hope this line will do, just like has been demonstrated in other states, is that it will reduce the disparities in treatment for maternal health and maternal mental health specifically. And just wanted to remind everybody, this is some language that came out of the HHSC Texas Clinicians Postpartum Depression Toolkit, but that both the American College of Obstetricians and Gynecologists and the American Academy of Pediatrics have very specific recommendations for screening in the perinatal period, with ACOG saying all women should be screened for perinatal depression at least once during the perinatal period, and AAP saying infant primary care providers integrate postpartum depression screening into the well child visits at 1, 2, 4, and 6 months. So to just orient us that we do want to provide services, and it is our intention to provide services. We're very excited to obstetricians, but pediatricians who are already engaged in our CPAN network will be high primary utilizers of a new PeriPan line as well. So screening, even though there are these screening recommendations, we know that screening does not equal treatment. And I want to thank Dr. Tabdina for allowing me to use the slide that she presented at the Lifeline for Moms Summit. That you can see these terrible conversion rates, if we want to use that language from earlier, to remission when only screening is implemented. We're really seeing for both antenatal depression and postpartum depression, very low rates of adequate treatment and remission. And our goal with this program is really practice level intervention so that we can sustain treatment, get adequate treatment, sustain that treatment, have symptom improvement and improved outcomes for moms, babies, and families. Just a reminder of the mental health professional shortage map in Texas, that Texas continues to have very high shortage in mental health professionals across our state, but wanted to also include this map. And this is maternity care deserts across our nation. And you can see that there are quite a few maternity care deserts. The light purple is if it's coming out light purple on your screen, is full access to maternity care. But starting in that orange and the dark orange and the red, we start to see less and less access to just general maternity care. So thinking across our states, especially in Eastern Texas, in the rural areas in Western Texas, and down in the Valley area, that we have significant restrictions in access to general maternal care. And so a line like PeriPan, like it has been for CPAN, will be very helpful in supporting the clinicians who are serving women in those areas. Just to remind everybody also that Texas formed a maternal mortality and morbidity review committee and had some facilitated a report in December of 2020. And finding number 3 was that obesity, mental disorders, and substance use disorders each contributed to pregnancy-related death, and provided some recommendations to improve access to integrated behavioral health care from preconception through 1 year postpartum for women with mental and substance use disorders, and then provided kind of drilled down deeper about what those recommendations could include or what those strategies could include. And I included the ones here that really overlapped with the PeriPan line. So using validated screening tools to screen all pregnant postpartum women, pushing that education, helping our clinicians do that, incorporating basic psychiatry and behavioral health training into medical providers' education to improve opportunities for intervention and treatment management, increasing provider education and technical assistance in national standards and best practices for the care of women with substance use disorders, and promote and use dyadic-centered treatment and recovery services. So for those of you who aren't in the child or maternal sphere of mental health, dyadic interventions are really looking at serving both mom and baby together and focusing on that mother-baby relationship through the intervention, which is a very evidence-based approach for what we call infant mental health, lower than like 6 years of age and less. So really, PeriPan will be focused on how our treatments for mom will really support babies' growth and development as well. And then exploring strategies to increase access to behavioral health care in critical shortage areas. And I highlighted over here on the side of the screen the different clinicians that we will be engaging across the state to collaborate to this end. Our obstetricians, pediatricians, as I said, our family medicine physicians who are engaged in obstetric or pediatric care, psychiatrists, psychologists, and nurse midwives. So as a reminder, CPAN expansion in the 3rd special session said that as a part of our expansion efforts, we can include perinatal mental health services. So that's what we're doing. This is the CPAN general map. And then the health-related institutions that have been identified as participating in this pilot are Texas Tech University Health Sciences Center in Lubbock, University of Texas Dell Medical School, Baylor College of Medicine, and University of Texas Southwestern. So these are the regions that will be covered in the PeriPan pilot project. So we know why we're addressing mental health treatment in frontline perinatal care, the same reason that it works in child and adolescent psychiatry care too. The disease burden is great. Mental and physical health problems are interwoven. Treatment gap is enormous, as we saw from those maps. Need for expanded access, reducing stigma and discrimination. It's cost effective and there are good outcomes. And I want to show you this slide that Dr. Nancy Baya graciously allowed me to share that she presented also at the Lifeline for Moms Summit. But what we're seeing, similarly to our CPAN type or child access programs that we're seeing across the nation in our perinatal programs, is that this builds provider capacity to deliver mental health care. So I was thinking back to those internal and external evaluation teams talking about how comfortable clinicians are getting this information, and that we are really building their capacity. So what this slide shows is that over time, our call volumes stay pretty much, they say relatively the same after you ramp up, but the complexity gets much worse, or much more complex. And we know we're really serving those primary care clinicians, those frontline clinicians, to try to get evidence-based mental health care. And they're feeling more and more confident about treating some of the things, anxiety, depression, but calling now about keeping even more severe cases, more severe symptom presentations in their offices. And this is overall increasing access to mental health care for many, many different diagnoses. So we are the 21st access program in the country. So we have a little star there in Texas, but just to let you know that this is really exciting with various funding from HRSA to state funded programs to grant funded programs across the nation. There are at least 6 brand new programs in the nation, but others that have been more well established, others that are utilizing new funding to really integrate their programs between their child and their perinatal programs, and then even other lines that aren't demonstrated here. This is not encompassing child psychiatry access programs, or some of the new addiction psychiatry access programs that are popping up. But it's really exciting to be a part of this consortium of sorts of all of these programs across the state, across the nation, where we're learning together best practices, learning from each other. And I want to share a little bit about what we've learned so far as being a part of that national group. So we'll skip down. November and December was really identifying the work that we were going to be able to do and the pilot sites for that and some budget work. And then in February, the PeriPan work group began meeting with representation from each of those identified PeriPan pilot sites and from the Central Operations Support Hub and the consortium administrative leadership. We talked last time about medical directorship, and also we met in February to approve those ARPA budgets. But what also happened was we started engaging the Lifeline for Moms program exchange that I was just talking about. So that is the organization that's facilitating all of this program exchange information between those 21 perinatal psychiatry access programs in the United States currently. And the very first thing that we went to, the topic of the very first program exchange, was how you partner and how you integrate with child psychiatry access programs. And this really looks like it has become a best practice. There tend to be programs and states in 3 different camps. One being that they've gone so far down the road that their programs really are separate, but they are looking at ways that they might be able to integrate in the future because they see the cost effectiveness of it. There's a second camp that really has received new funding. So they've had their lines established for quite some time, but they've received new funding to now integrate those lines and really present them to the clinicians, as we saw that overlap between obstetricians and pediatricians and family medicine physicians who will be calling about both things. They have looked at, many states are looking at utilizing new funding for integration and working on the integration process. And then there's the third camp that's really already far down the integration process or started as an integrated model for serving those clinicians who are taking care of mom and taking care of baby, whether it's a pediatrician or a family medicine doc or an obstetrician who is always considering both mom and baby and what's going on. And then in March, we continued, Lifeline for Moms had a summit that we participated in. We met with the Texas District for American College of Obstetrics and Gynecology leadership about our program and presented that, and met with HHSC about all of the resources that are available, the continuum of resources that are available for women who are pregnant and postpartum in Texas in order to form a guideline and really get some recommendations for our teams as we're rolling out this training about how to recommend utilizing several of the programs that already exist in Texas, understanding what gaps exist and how we can help fill those in the future. We met with North Carolina and Michigan and about their programs. Again, North Carolina Maternal Health Matters is a program that has had NC PAL, which is their Child Psychiatry Access Network, and NC Matters, and are now merging those together. So it was really interesting to look at their EHR system and how the advocacy work has happened and how they've integrated that over time. M3 in Michigan really has been integrated since the beginning. And so we were able to talk to them about how someone calls their line and gets both access to a child psychiatrist if they need it, or a perinatal or reproductive psychiatrist. So again, we continue to meet with these groups and including looking at some AIM bundles from the ACOG and how we could utilize those and distribute those. A big portion of PeriPan, just like CPAN, will be the education that we push out and disseminate through echoes and grand rounds and just materials that we disseminate to our engaged clinicians and our enrolled clinics. So we really wanted to identify what are those best practices, what are the things coming out from AAP and ACOG and the different professional organizations that we can help assimilate and we can help organize and distribute for everyone. Then we did a fun Twitter chat with HHSC for Maternal Mental Health Day, which was May 5th. So that was super exciting, or May 4th this year. And we had a PeriPan kickoff meeting with all the pilot site key personnel. And then throughout this time, and we've begun our training. So weekly training meetings for all of these different pieces. And then ongoing throughout this, we've met with the trait team, discussed with the Lantana team, really looked with internal and external, or mostly internal evaluation team, the data and metric discussions and how we're going to gather all of this information, how we're going to separate it from CPAN information and tell this story. So our take-home points is that integrated networks are the wave of the future. This provides a streamlined process for busy clinicians who are often calling with questions about both, and it gives them one line to call, not having to remember, which line to call in which situation. Operates at a cost savings compared to separate lines and having separate teams, and then really strengthens advocacy efforts. So you have multiple professional organizations that you've engaged and clinicians all saying, yes, this integrated line is very helpful to me. Our goal is to expand PeriPan services statewide in a cost-efficient way. We're already hearing in our ACOG meetings and our other meetings, when is this going to be available to everyone? Whoops, not just in the designated pilot sites. And so we know that that is already an identified desire, want, and need for our state. So we'll be looking at that. And then we also identified that some of the programs in other states have direct services to assess women with complex mental health presentation, just like we are expanding CPAN for that direct assessment. So as that's not a current, the pilot is not currently funded for that, it is something that we will be looking at in the future. Again, these are, we'll talk about how these are sister programs, but CPAN and PeriPan really engage many of the same clinicians. They provide the same service, especially with that frontline resource call, and then provide the education. So there are a few changes, and those are the ones that I've underlined here, engaging both obstetricians and psychiatrists and PeriPan. And then behavioral planning and psychiatric consultation being focused on the woman for PeriPan. But really those frontline call answers, and even the psychiatrists often will be answering questions about that dyad, the mother-baby pair, and what to do to support them. So this is the support structure for PeriPan. Again, they're sister programs, CPAN and PeriPan. And you can see they will be overseen and directed in the same way, with Kosh being a facilitator of the operations and standardizing the practices across all of our teams. And then with executive director and the executive committee. So Lantana, currently, this is the basic framework with one change for the Lantana script. So the Lantana is the phone system, phone company that manages the line for all of our clinicians calling in. It is facilitates the ability to transfer calls between hubs and really look at those metrics of who's calling in, provides that one number that we voted on a long time ago to make it easier for clinicians instead of providing multiple numbers. But then you click which region that you would like and then which hub. Currently, the language says, welcome and thank you for calling the Texas Child Psychiatry Access Network. The recommendation here, after discussion with all of these other teams across the nation, our administrative team, and with Kosh, is really to only take out the word child, so that it says welcome and thank you for calling the Texas Psychiatry Access Network. But then when you drill, and everything else stays the same, so that there's not confusion for the pediatricians and family medicine docs calling in, that one minor change shouldn't alert them to anything. The structure is exactly the same. And then for the obstetricians and psychiatrists and people calling in, that it wouldn't give a secondary, wouldn't say Texas Child Psychiatry Access Network. And looking at all of the different versions and options we considered here, this seemed to be the one that facilitated getting people to the right pilot site as efficiently as possible, and not having confusion between pilot sites, and also having having Dr. Lakey, I see your hand. Let me finish this statement and I'll stop. But also having it be as less not confusing for the people calling in. Dr. Lakey, did you have a comment?
No, I just wanted to stop here for a second, okay, because this is a change that needs to come in front of the executive committee as Dr. Wakefield has noted, that when people call, referring to it as the Texas Psychiatric Access Network versus the Child Psychiatric Access Network, it is a little bit awkward for some institutions that haven't set up, aren't able to be part of this PeriPan pilot yet. Then the hope is that we're going to be able to do this very quickly and try to make it statewide, but just want to make sure everyone takes a look at that. And again, we're committed to make sure that all institutions that are impacted have a voice in this. And Dr. Wakefield has had a motion. I'm going to need a second, but before I do that, Dr. Pliska, I see your hand.
Yeah, the PeriPan doesn't cover the whole state, right?
No, it's only going to.
How will, if someone's calling in and they're not in a region that has PeriPan, how will that, because they'll hit how will they be redirected?
They won't. And that's exactly the reason we want to do it this way, is that it wouldn't change anything for the places calling in. And it might help, Dr. Lakey, I'm not sure, but it might help for me to explain how trait is going to work so that people can have a better context before we come back to this. But either way you want to do it, I'm happy to. But Dr. Pliska, just to let you know that the reason we wanted to leave it like this is that it was less confusing for those regions who will not have a pilot. So their system stays exactly the same.
But if someone from El Paso hears about PeriPan and he calls in and he presses 4, what happens? That's what I was. What feedback is he then given? Who tells him, no, you're not in the region that's doing PeriPan?
So that's a very good question. And when that call gets to the hub, they will say, we don't currently have PeriPan services because we're not a PeriPan pilot. And so this really keeps the people who are in that region calling their hub instead of having an option for them to call a separate hub. What we wanted to do was try to keep it as clean as possible so that the people who are in the non-PeriPan pilot sites, nothing changes for them. They just
we just need to train our people that, or when you say hub, you mean the central CPAN people answering the phone?
I mean the HRI.
Yeah, so here in San Antonio, our CPAN people will get a call and say, well, I'm calling about a perinatal thing. We say, we don't have that here. And that's what I'm concerned about, how that's going to work and how it's going to come off.
We're going to have 1 year of it being just a little bit awkward. But in order for us to build it out the way that we need to for long-term success, we need to move through this the way that we're thinking through it based on the input of other states. And so what would happen, Steve, if somebody called San Antonio? They're working on the script, but the basic message would be that thank you for calling. Currently, our institution is providing CPAN services, but PeriPan services are not yet available in this part of the state. Hopefully, they'll be available in the future with some additional wordsmithing related to that. But we'll have to be clear that service isn't in that part of the state yet. We're not going to market it in that part of the state, but other people will hear about it. But that's what we can do right now until we get through the next legislative session and hopefully secure the funds to be able to build it out in the rest of the
So
state.
you'll give us a standard script for that.
Yes.
Very
Yes.
good.
Joe, I see your hand.
Thank you, David. Sarah, that's such wonderful work. So impressive to pull this together in a brief period of time, and on top of the million other things I know that you're involved with. So this is really impressive. I do have a question concerning nationwide. Is it your sense that programs uniformly focus on just this, as you say, perinatal period, or are there some that kind of take a more generous definition of maternal mental health, regardless of time since most recent childbirth? And pedantic question from that is, what exactly is the definition of perinatal with respect to the postnatal period?
So Joe, I'm gonna, if Dr. Wakefield can answer that quickly, but I want the conversation right now to be on this change in the LATANA call to make sure we get that approved. And then
I'm sorry, I didn't realize there was a motion pending around that.
And then we're gonna go through the rest of the presentation, but this is a change that needs to have executive committee approval. So I'm gonna, if it's okay, make sure that we vote on this and then continue the conversation and then go to more general conversation.
Absolutely, I didn't want to mess up the continuity of what you were doing. I apologize. Mhm.
Any other questions related to this little change in the script? Hearing none, I have a motion by Dr. Wakefield. Do I have a second from another executive committee member?
I'll second, Dr. Bryant.
I have a second from Dr. Bryant. Any other further discussion? Hearing none, seeing none, all in favor of changing as has been noted, please signify by saying aye.
Aye.
All right.
Okay. Anybody abstaining? Right, very good. So Sarah, we have approval for this change. I'm going to hand it back over to you, but Joe will get to your question as soon as Dr. Wakefield gets through the rest of her presentation. Okay.
Sure.
Thank you.
I do have an answer for you, Joe. So I will try to remember. All right. So I think it doesn't look like, oh, here we go. All right. Sorry. I got confused on my presenter screen. So in one of the things that we learned, or one of the things we want to do, is make it as easy as possible to collect information and to pass that on through our teams. And so what we've talked with Trait and what Trait is building is an integrated access platform. And we took best practices again from some of the things Michigan's doing and North Carolina's doing and New York is doing and Kansas, and looking at all of these different programs who are working on these integrated services and try to take all those lessons learned so that we don't have to redo things in the future, and also really try to look far down the road in case we added additional lines in the future. So you can see this, and I want to be very clear that we don't have an addiction line. We're not doing an addiction line right now. This is an idea for if we build this, Trait is building this one access portal so that we can have maternal health information, child and adolescent information, and potentially other kinds of information all in this one portal going forward. What will happen is, again, Dr. Pliska, because I think this is very, very important. We have spent so much time thinking through what we hope is a very brief transition time where there are only 4 pilot sites, what it will be like, what the experience will be like for the non-peri-pan pilot sites, but then also not building something that we'll have to pay to rebuild again in the future if we do expand like we hope statewide. So what we have looked at are just a few brief, and I'm not going to go through all of these changes, but I wanted to let you know that the goal that Trait has done is that there are very minor changes. I'm sorry. There are very minor changes to the CPAN experience for those frontline clinicians, that they are able to answer the phone, take that information at those non-PeriPAN pilot sites, and go through their process, with the caveat that there will be a designation on whether the person is pregnant or not, so that we can start to collect that data. Otherwise, for the CPAN non-PeriPAN pilot sites, everything will be the same at those sites. However, at the new PeriPAN pilot sites, that frontline clinician will be designated whether they're collecting perinatal information or that child information based on that pregnancy-related question, and then we'll be able to pass that call on either to a reproductive and perinatal psychiatrist or to a child psychiatrist. The coolest thing about this is that Trey, in their magic that they do, will be able to actually have the phone call, two things actually. One, that if I'm trained as a child psychiatrist and a perinatal psychiatrist. So I am manning the line that day, I can take calls for both of those services. And my platform, my access portal, will be enrolled in both of those things. So I can see all of the different calls from both programs. As a clinician, I'm not having to get out of one screen and into another screen. But if I'm only enrolled as a child psychiatrist, I only see the child psychiatry consults. And if I'm only enrolled as a perinatal psychiatrist, I only see those perinatal consults. So we're really excited about that functionality. We think it will improve teams' abilities to really be nimble and best utilization of their resources, which could reduce costs in the future as well. And then the second part is that we know that there are young women and girls who are pregnant, and there might need to be the weigh-in, or it might benefit from the weigh-in of both a perinatal psychiatrist and a child psychiatrist. And in the trait build, you will be able to, if a perinatal psychiatrist is first answering the question, but saying, hey, I really want a child psychiatrist to weigh in on this as well, you can pass that consult in trait, and the pediatrician or the obstetrician or the clinician who's calling doesn't have to hang up the phone and call again. That we can facilitate, Trade is facilitating the ability of us passing the consult to each other when necessary. It's not something we have to do, but when necessary, based on the expertise at your hub, to facilitate the easiest response to that clinician who's calling in, because we really want it to be both user friendly on the clinician calling in side and the clinician answering the phone call side. So we're super excited about both of those functionalities. Looking ahead, Kosh is facilitating these operations meetings now. So we really moved into this training and getting prepped and working very specifically on the components for go live. And on March 10th, we met for looking at that initial phone call and what that looks like. All of these trainings and meetings are being recorded so that we can archive them and have them available to any new team members that you're onboarding. We have some specific one-on-one HRI meetings coming up, and then a Lifeline for Moms training. What I'm really excited about, that this will be in July, and we'll have gotten information from each HRI and on our own trainings so that we can take all of the information we've learned in CPAN and know what those specific questions that we want Lifeline for Moms to help us with, so it can be really tailored training for our state. These are some of the trainings that we've already disseminated and recommended. Some are free, some cost money, but really looking at utilization. Dr. Blader, you sent me some trainings that we'll send out from New York State. It's really exciting, especially this Lifeline for Moms exchange facilitates a lot of discussion on what these best practices are and what how we can learn from each other in this. Our line launch is still planned for August so later this summer, and Trey is busy working on that build, which will be our limiting factor. But they believe that they'll have the enrollment portal up and running prior to the entire build being done, and so we will engage and talk with the HRI teams about that enrollment. Just to remind everybody, as Dr. Lakey said before, we will be enrolling in those targeted areas. And so the education that we are going to give will be about those areas. I'm speaking later this year in September to the ACOG District 11 meeting. And every time we engage our stakeholders and our partners, we do tell them and educate about the sites, the areas that these pilot sites are in, and the ones that we are not yet in. And then I just wanted to let everybody know about this because it's really, really exciting. HRSA engaged Postpartum Support International to develop a specific national maternal mental health hotline. This is for your patient, for a woman to call if she is struggling and needs resources and de-escalation and someone to help right now. It's 24/7. It's free, confidential hotline in English and Spanish. And PSI is providing the clinicians to do that. So a very reputable organization. And we also will be working to put our information on the PSI site once we go live or get closer to that go live date. But I wanted to let everyone know that this resource is currently available. It has just gone live and they do a warm handoff when necessary to the National Suicide Prevention Lifeline. So there's a lot of collaboration there looking at those national mental health hotlines. And I know, Dr. Blader, your question was first, so I'll answer that. It really is designated in a couple of ways. In the states that are state funded, the definition of the demographic served is usually in statute about what that means, what that definition is, as it currently is in Texas for the pregnant or up to 1 year postpartum. If it's HRSA funded or funded from some other grant application, that definition has typically been delineated in those applications. Now, as a reproductive and perinatal psychiatrist, and as someone who's also a child psychiatrist, we think about infant mental health when dyadic interventions are the most evidence-based interventions, when helping mom is the best thing you can do for baby, really 6 and younger. So there's a difference in some of these, who the program's serving and what the evidence is in the actual care delivery.
Sarah, we have one more question from Alex. Dr. Vo?
Thanks, Sarah. I have a question regarding the integrated platforms and all the platforms that are being built by Trait. Who technically owns the IP for that? Is that a lawyer question or a Kosh question?
I was going to say, I think that's at least a Dr. Williams question and maybe a lawyer question as well.
Let us get back to you on the exact legal framework on that. Okay. Yeah. Yeah. Yeah, that's a good point. No, a good point.
We can't hear Dr. Vo when we're on.
So Alex Vo's question was, who owns the intellectual property related to the integrated Trait product? And he noted that he thinks that's very important. And my comment to him was, let me get back to this group to give a exact answer related to that. Okay. Very good. Yep. Joe, do you have another question? Your hand is up. Joe, I can't hear you. Oh, the hand's down. Okay.
Actions speak louder than words, so I got it down.
Very
Sorry.
good.
Thank you.
All right. Thank you, Dr. Wakefield. Obviously, a lot of work in a short period of time. We're trying to ramp this up very quickly, so we have a story to tell going into the next session. Again, the goal is to make this statewide. We've been transparent related to that since the beginning, and we'll need to quickly run in order to have that kind of data and service that will be able to convince the legislature that this really is a great idea and a need for the state.
Well, and thank you, Dr. Lakey. I just want to make sure I say thank you to all of the participating HRIs. It has been, we have learned so much together and from each other. It has been a really collaborative and fantastic process. So I look forward to continuing it.
Very good. I'm going to jump back and do one more thing, and then we're going to break for lunch. But I skipped over Michelle to give an update related to the reimbursements on research. I don't want to forget that. So let's do that, and then we're going to have a break for lunch.
Sounds good. I just have received a lot of questions from HRIs about the process for the research reimbursement. So I just wanted to go over the process one more time. And the February meeting, we talked about changing the way that those reimbursements worked. Prior to that, so for Q1, if you do have any research reimbursements, I need the template for reimbursements paid, And then for Q2 moving forward, if you want to get reimbursed, I need you to execute your PIA amendment. And I also need account information on where those funds need to be directed on your institution side. We will be relying on the hub reports on what were the numbers recruited. And so we're not receiving invoices from you. There will be a true up process at the end of the year. However, to date, I've only received I have 5 fully executed PIA amendments, but 2 of those are missing account information. I've got 2 PIAs that are in process, and then the remaining 5 out of the 12 I have not received. So if you are wanting the research reimbursements for Q2 moving forward, I do need you to execute those agreements. And if you have any questions about where your HRI stands in that, feel free to reach out to me.
Very good. Any questions for Lachelle? Seeing none, we're going to break for lunch. Let's reconvene at 15 till. And so that gives us 35 minutes for lunch. We need to start on time because we still have a lot of discussion left for the day. And we're going to need to make sure that we are, with the presentations, make sure we're concise, because again, I'm just going to watch on the clock and make sure we get everyone out on time. And so we are going to, very good. We'll start again at 12:45 and have a good lunch. Thanks.
Oh, Jim? Jim still there? Oh, I was just gonna let you know, you left your mic on in case, someone's in your office or something. You might want to mute there before you leave your computer.
Oh, thank you.
I've done that and I regretted it.
Welcome back, everyone. It is now 12:45, and we're going to go ahead and get started. Before we do, if there's any executive committee members that have joined us since the last time we took roll call, if you'd identify yourself quickly so we can document your attendance, please let us know you're here. I see Andy Keller. Thank you, Andy. Anybody else? All right. Carol Tominga, I think we got you last time, but I want to make sure we have you down. And I think that's Peter, Dr. Thompson. Hello. Well, anybody else? Lynn, you good? I also want to recognize Dr. Roxana Cruz, the medical director for the state's federally qualified health centers across the state, is here with us today, and I appreciate you being here. It's been a strong partner for the work that we're doing. So great to have you here. All right. With that, why don't we go ahead and jump back into the agenda. I have us at 3C, and we're going to have an update, again, going through the updates of the new ARPA funded initiatives. And the next one is the collaborative care by Meadows Mental Health Policy Institute. Andy, we're going to turn it over to you.
Great. Well, I'll talk a little bit to the, I think I only have one slide. Well, I have a cover slide. So there's the cover slide. So here's the slide. So basically what the slide is saying is that we're in the process of getting the contracts put in place. And so of the all 9 HRIs, we've had initial meetings and people have had questions and we're sort of working through those. But one thing we've tried to let people know is that their questions are actually part of why we're doing this. Like we're not going to have you understand this right at the beginning. We're going to work on this together. And that's going to do two things. It's going to help you and your team understand what we're doing through this broader Lone Star Depression Challenge and kind of how it fits into that. But it's also going to help our team understand the unique challenges and opportunities in the health systems that you all know so well. So, what we're basically trying to do is answer enough questions so people's anxiety is manageable. And then we kind of proceed together and figure it out. So that's kind of been the nature of that. And I'm happy to, after I'm done here, answer any questions folks want to bring up with the group. We've begun, though, the process of identifying health systems. So, we have 18 health systems that we're going to engage during this 2-year project. And we have 2 of them identified formally, where we know what we're going to go do. And we've identified that with the HRI. But most of them we haven't. And again, that's okay, because we want to discover that and figure that out together. And also, even after we identify them, doesn't mean that is the health system we're going to work with, because they get a vote too. We can't just draft them into doing it. So part of our plan is kind of what the initial health system will be, and go from there. So that's where we're at. And I just maybe to comment on just the contracting discussion from before lunch. One reason we are going through the changes we are is we didn't know when we set this up exactly how the fundings were going to flow. One thing that was really important to us and why we initially had the funding flow through us is we have to align what you do with the Lone Star Depression Challenge that we're working on, because the only way we get efficiencies from our team is if we're able to leverage the, it's actually over $10 million, I think, because we have several aligned grants that go with that. By leveraging those other funds is the only way our team's able to engage on this, because with a lot of these HRIs, we don't get any funding at all. We're just partnering with HRIs. We have funding coming from other sources. I mean, we're not hurting for funding. We just don't get it through this process. So we wanted to make sure it was aligned. So what we've done instead now, because, I think it's like $7-8 million in this whole kind of project, over 5 million of that goes to the HRIs and health system. So for us to cash flow that on a prospective basis as a $20 million organization just wasn't doable. So, so in order to not have you all be delayed, by that or problematic, and also to not have us sort of have to do strange financial things, we're working with UT on that. Now, the thing though that's tricky on that is we still have to have the requirements of the Lone Star Depression Challenge written in to those contracts, as well as to the agreements that we'll have with the health system. So it makes them, they're contracts between you and UT, but we have to sign off on it in order to align our funds with it. So it will be a little bit, it won't be, sort of the one-on-one conversations y'all are probably used to having. And we're still working that out. That's why it's going to take a little bit longer. But I think things are moving ahead pretty well. So happy to answer any questions about that or anything else folks want to talk about.
Very good. Any questions for Andy? And Andy, I don't see any hands in this room or any others being raised, but again, thank you for the work that you're doing. And obviously, if people have questions, they can reach out directly to you and your Meadows team in order to make sure we're moving forward. So again, thanks. That's good work. Next, let's go to Dr. Joe Brader and the Substance Use Disorder Services initiative that he is helping us to lead and teach at. Joe?
Okay. Am I visible? Well, me and the slides. Let's get this sorted out here. Okay, well, there's me. Can you all see the slides?
We can see both you and the slides now.
All right, perfect. Okay, at our last meeting, we talked a bit about the rationale and the underlying purpose of what is essentially an enhancement for TCHAT to more directly deal with some of the issues posed by youngsters referred to TCHAT who also have significant issues with substance abuse. Today, I want to fill folks in on how our overall treatment model has gotten fleshed out and where we stand. As a reminder, here are our collaborators. We have 5 sites that are partnering in this undertaking. There's us here in San Antonio, Texas Tech Health Science Center in Lubbock, Tyler, and UT Health at Houston, and Del Med in Austin. In addition, we've been very fortunate to have terrific feedback and involvement and guidance from the Danette Castle's organization representing the local mental health authorities. I know you, David, and Luann have been helpful reaching out and contacting, linking us up with some folks at HHSC who've also been very helpful. And throughout the overall response that we've gotten from other groups that we've tried to discuss our project with has been super encouraging and reinforcing. So thanks all for that. So I'll say I want to go over what the objectives of our project are. And I'll start by going over what the SBIRT model consists of, because that's what we're aiming to implement. So the SBIRT model is an acronym: screening, brief intervention, and referral to treatment. So our first initiative is to implement uniform screening for alcohol, drug, and nicotine use throughout TCHAT services at participating sites. The tool that we've chosen to do this with, the CRAFT 2.1N, already exists in trait, and all sites have been working at addressing how we're going to cull those data in real time when patients are seen or evaluated. So we know their status with respect to current level of use, if any, because that then directs what the next steps are for that individual. In addition, each site also has to provide kind of a backup plan in case the TCHAT assessment for various reasons isn't done before the visit, or there are other difficulties with that. So the goal is to get very high compliance with the screening protocol. That's then followed by brief intervention that's calibrated to the results of the screening. So as I'm sure many of you know, the basic idea is that if there's no indication of use from the screening, well, that's when we reinforce kids and families. It's wonderful to see you're making such good decisions for yourself, and and so forth. The next stratum would be a kind of infrequent use that clinical judgment figure, you kind of figure it's relatively low risk in the broad scheme of things. And that's where the person who's actually doing the screening then provides counseling, some initial motivational enhancement techniques to see about reduction or discontinuation of that kind of infrequent use before it coalesces into a more serious problem. And finally, for those who have more serious use, usually in this field to mean somewhere between monthly use or certainly if you get to the level of weekly use, then that's where referral and assessment by our specialty care teams at each site is indicated. So then what do those specialty care treatments consist of? The strongest evidence for adolescent substance abuse disorders involves family-based approaches, along with cognitive behavioral therapy, as well as treatment of any other underlying or comorbid psychiatric problems. Generally speaking, the duration of treatment seems to be in the 12 to 16 week acute treatment phase, plus some follow-up and booster sessions. That's the prevailing approach that that you see in the literature. And what's innovative about what we're proposing to do is that we'll be having telehealth as the mainstay of treatment delivery in this context. Not 100%, of course, but much like the way TChat is designed, it's going to be our default. And we're undertaking to have a team of TChat clinicians who are going to be trained up in this enhanced family-based approaches for substance use at each site. And then finally, our fifth objective is to provide education and training to the community. So for starters, in primary care, we want to play a role in improving training and screening and brief intervention, which after all is consistent with the American Academy of Pediatrics guidance for annual screenings of these issues. And then we'll also branch out to providing education and background and various tools for in schools to increase awareness of the mental health context and principles of treatment for youngsters who are using substances. So what's our timeline? Where are we at? Well, by June, we're on track to have screening via the CRAFT 2.1 plus N throughout our sites. We're going to use, as I mentioned, trade and a backup method for data capture. And we're also hope to have in place our training to all our TChat clinicians in brief intervention. So this is the principle that you've already done the intervention. You have, I'm sorry, the screening, you have the results in hand, and based on that, that's going to direct the interaction that you're going to have with the teenager. By July, we are hoping that we'll be getting referrals to the specialty care component, those kids who have a pattern of use or their use poses risks that warrant pretty direct and comprehensive intervention. And we're also coincident with that, we're going to get advanced training and supervision in family therapy from, we'll have a menu of providers for that. There are some folks who specialize in this area. HHSC has some offerings along those lines. So we'll be going through all that to see which best meets the need for the patients that we have. Hopefully by the fall, we'll be in a position to diversify the referral base beyond TCHAT. That became part of this project's remit to serve as a resource for other community providers. And later on in the fall, that's where, by then, that's when we can begin to shift our attention to training in primary care in the expert model to help them do the screenings and brief interventions and hopefully equip them with some tools for and resources for referral to treatment when that's warranted. And we'll continue our training and skill upgrading activities with advanced training and evidence-based protocols for substance use disorders and its common comorbidities. What are some of the pending issues that we're trying to sort out at this point? Well, the question comes up in the substance abuse world. Well, what about labs and how you're going to figure out if people are really being abstinent and so forth? And in the adolescent field, among the experts that we've talked to, compared to the adult world anyway, there's been some softening on the need for universal insistence on getting urine screens for adolescents. And some people have come to the conclusion that perhaps it ends up causing more strife than benefit. Which drives us in the direction of taking that on a case-by-case basis, as well as a specific methodology for obtaining them outside the lab. We've had some consultation with Jennifer Potter, who is one of the leaders of the statewide opiate treatment initiative in the state. And evidently there are some home-based tests that you might be able to do. And if they're required, if the samples are required correctly, then you can have adequate confidence, but that's all to be worked out, working out the decision rules that weigh the benefits and disadvantages in a particular case. Another major issue, of course, this is not unique to our project, but difficulties in fleshing out our staff complement, staffing issues. We're trying to avert delays being caused by the tight labor market and bringing people on board, especially for licensed staff. So some of our sites are pretty much set with being able to implement this program with existing staff. Others might be a bit delayed getting underway because they're pending getting adequate hiring and onboarding people. Another issue that we're grappling with is, well, what are meaningful clinical metrics in this situation, or for this type of clinical presentation. So substance and alcohol use measures are standard, but in adolescence, I think we also want to get some other functional and symptomatic outcomes, because it's once in a while you could have a situation where substance use is sort of the sole problem, but generally speaking, there are so many comorbidities and other adverse impacts in the kid's life that we need to take perhaps a broader frame for what we're trying to help people with. And finally, there was interest in our group in adopting the CRAFT 2.1N, which includes a module specifically for nicotine use in all its various delivery vehicles, vaping, cigarettes, chewing tobacco, and so forth. It's easy to screen for those things and then give kind of the basic, say, doing the brief intervention for those who are kind of just experimenting a little bit. But for people who are really essentially tobacco addicted, well, what are we going to do? So we're having some discussions about whether how that would work in the context of overall TCHAT. Should we be sending folks to quit lines or more direct service? Those are things that are a little bit down the road once we get the core program up and running. And that's my summary for now. And I'm happy to engage in conversation with your comments and suggestions. Thanks.
Very good, Joe. Thanks for all the work in setting this up. We have about 5 to 10 minutes if people have questions or comments. Octavia, I see your hand.
Joe, really great stuff. Just a quick question, just to be sure. It'll also include vaping?
Yeah.
Okay, because I mean, as you well know, and everyone here does, it's really been just really devastating for some families.
Yeah. Dr. Pliska?
I think, yeah, I wanted to emphasize the staffing issue, which I think is we're really needing to staff up multiple projects. And, many of us, I don't know how it is, certainly we have a number of openings already, both in the consortium projects, just in our general department projects, as we're going through the great resignation and the escalation in salaries in the private sector. And I think it might be a topic, possible suggested as a topic for a future executive committee meeting if we run into difficulties in this area. One simple area that's been difficult for us is the health science center pay scales are fairly rigid, and it takes almost an act of Congress to change them, to raise them so you can be competitive as salaries change in the marketplace. And I don't know, to the degree that that's a general problem, we might want to address it as a consortium, and also appeal to the leadership of the various HRIs, because there may need to be exceptions to longstanding HR policies so that we can not be hung up by staff shortages in executing these things. But I don't know, maybe if it's not a widespread problem, we don't have to address it, but it's something I want to kind of bring to, it's something we're struggling with, and I don't know if it's a common issue.
Steve, I guarantee you're not the only institution that's challenged right now in recruiting individuals. I see several heads shaking affirmative as we're all trying to move through that. But I take your suggestion, and maybe we put that on the agenda for next time to talk about the overall workforce challenges that we have as we're setting up these projects. Dr. Bryant, Beverly?
Yes, I would just echo what Dr. Pliska said. We have a number of positions that we're recruiting for, and we have an ongoing problem with our human resources department, just getting positions posted and then getting it funded at a reasonable level. So I totally agree with that. And anything that could be done to help would be fantastic. We're training some folks that we already have so that we can hopefully get started. But we really are depending on recruiting a couple more positions to really be able to jump in with both feet.
Very good.
In fact, I have a quick story. One morning, the head of our TChat program called, "Great news, Dr. Pliska, we hired another therapist." I said, "That's great." Then I went into clinic that afternoon. My patient came in and said, patient's mother came and said, "Oh, bad news, Dr. Pliska. Our therapist quit. She says she's going to be working for you." And so we're pulling out of the community, which is good. We want to execute these projects, but it shows how the limited number of people that there are available.
And I would say that's why the workforce component of what we're trying to do is also very important as we continue to build that workforce in Texas. Sarah, Dr. Wakefield?
Yes, I would also say that because of the workforce shortage, which we've always had, this is not a new thing in mental health, although it is, exacerbated recently, but that I truly think that these programs that we're building with a triage component, an initial screening, a brief intervention component are so very important because so often we have people getting services that they're not actually benefiting from and there's no evidence base for. And if we can build these teams that have these different, just like as part of our TChat processes and as part of this substance use disorder process, where there's screening, there's brief intervention, there's rescreening, there's only referral through to the expert level of care when you're really needing that level of care. And that to me is another component of what we're doing to really address the workforce shortage area here too.
Very good. Good point.
Thank you. Great.
All right, Joe, I don't see any other hands, but again, appreciate the work that you're doing and look forward to its success.
All right, thank you very much.
Thanks. Let's go next to Dr. Trivedi and the Youth Aware of Mental Health program that they're setting up. Dr. Trivedi?
Wonderful. Can you see my screen?
I can see it in slide sort. There it is. Very good.
Thank you. Thank you for the opportunity to talk about this. I think we have been making a lot of progress, and I'll give you a little background because this is the first time I'm talking about this, so we put it in context and then talk about where we are with the project now. Obviously, we've really identified the team here for the. Did somebody say something? Sorry. So we've identified the team here. Dr. Toby Fuller, thankfully, was running this medical school education program. And so she has moved to us. She is an ED, has worked in schools. She has been a nurse and also training in medical student education, and then a number of other people. So we, at least at the coordinating level, we have now identified the staff who will be able to do this, and I'll give you a little background on that. And then we have all the 8 leads for the HRIs who are going to be really our true partners in this. We've been having individual as well as group meetings, and I'll talk about those. I can, if any of them you are here, you can introduce yourselves, but I think this team is really gearing to go and in line with what everyone is talking about, the contracts, et cetera. Once they're in place, they are ready to be recruiting and hiring people for that, and we'll give you an idea about each of the HRIs as I go forward. So this is a Youth Aware of Mental Health program. Just to put ourselves in the context, it's an evidence-based program that ensures youth participation rather than just a didactic kind of approach. It is delivered to the entire classroom by certified facilitators in the classroom setting itself, so that it is almost like they get a health class. Instead, they get this. It's a 5-hour interactive mental health promotion program. It can be delivered over 3 weeks or 5 weeks. So either Monday, or once a week for 5 weeks. It really encourages the participation and discussion, increases knowledge about mental health, develops problem-solving skills, emotional intelligence. And I'll give you a little bit of the data from what we've been doing in the North Texas area in preparing for this project to launch. So the program history, this has been well documented. It was done as a randomized control trial in Europe. It is seen as a school-based prevention program. And they developed it in Europe and tested in 2 studies. Initially, it was developed with adolescents from 9 countries on 5 continents in a study, and sponsored by WPA, World Health Organization, and international groups. It is later tested in young lives as a study itself in a randomized trial. The 3 interventions they studied in that study, which is why it is actually very exciting. They used a standard approach that a lot of places in the country use called question, persuade, refer, designed for teachers and school staff. And majority of school programs are basically what I call gatekeeper programs like QPR. They compared it to professional screening and, so to speak, best care, best practice, and then youth aware mental health. It included 11,000 students, evaluated baseline 3 months and 12 months. Remember, they did only the 5 sessions, and it was seen in 168 schools in 10 countries. There was, at 12-month follow-up, this YAM was associated with significant reductions in actually new incident suicide attempts, severe suicidal ideation, and depressive symptoms. So, and now since then, we have a big paper coming out from our experience in the last 3 years. And next time, hopefully by then it'll be in print, so I can show it to you, where we also in a group of 14,000 students in North Texas have been able to replicate these 3 findings. So the program, as I mentioned, is a 5-hour interactive program. It includes basically the program itself. In addition, there are booklets, there are discussions, there's role play, there are posters as put in the classrooms. And the themes it covers is what is mental health, self-help advice, stress and crisis, depression, suicidal thoughts, helping a friend in need, and who can I ask for advice. Concretizing, as Joe was saying, about what does it really mean kind of thing. We have documented in that paper I was talking about, where there is significant increase in help-seeking behavior as well as mental health literacy as a result of this. These are the kinds of posters that are hung in the classrooms themselves, so that the students not only get the 5 sessions, but it's within their classroom posters for the whole year. So there are constant reminders of the program they engaged in. And for this starting of this, we've been proactive. So even before all the contracts and everything was signed, we connected with the HRI leads who are going to do this, and thankfully they agreed to participate in our calls and all. So we've done individual as well as groups. And by the way, Danette and Sonia Gaines, and we have met several times, and they have been really very helpful in advising. And then Lachelle and Luann have been with us throughout this. We've had several calls as a group. So this is implementation discussion in depth about YAM, status updates. We keep on bugging them. So if any of you are on, please forgive us. We just want to be ready to start as soon as we can. And we've now been having weekly status update meetings. This is really the basically lay of the land for us in individual HRIs, and you can I'll pick out a couple of them so that you can see this. For TAMU, for example, there are 106 ISDs in the region, 91,000 students that can be approached. Similarly, for Lubbock, 219 ISDs and 11,470 students that can be approached. Lubbock covers more area than most countries in the world, so Dr. Wakefield will identify that. But nevertheless, the idea is that all the regions have access to significant large numbers of students that they can go to. And thankfully, all the HRIs have had connections with school ISDs through TChat. So our recommendation to all the HRIs has been to start with the TChat schools where you already are. There is a 10-point plan we have for engaging. As you all can imagine, it is not the same as just our current TChat approach, where some student is identified to having a problem, and then the next steps follow. This one, we have to go to engage the entire classroom in terms of, therefore, all the stakeholders have to be brought along. So that it has to be the school teachers, the parents, the counselors, their schedulers for their curriculum, the principals, and even the superintendent of the school board. Our idea is that we have 4 teams per HRI, and even if you just look at the times when schools will be willing to do for the 4 teams, we can at least get 7,920 to 10,000 students from that. And that is just the 4 occasions in a school year. At the beginning, for example, when we start now in the fall, then again in the spring are the 2 periods we get with them. But then between those times, there are a lot of youth organizations that can also be approached, like YMCA, et cetera. And we've been working here with local mental health authority and pediatric practices also, where we can get engaged with many. We've begun to develop a lot of the materials for this so that it can be helpful for assistance in each of the HRIs when they want to do something in terms of communicating with the schools, with parents, et cetera, so that there are flyers and we've been working with each of the HRIs. They can modify these. These are just something we have used and are available as a resource. We'll put it on a website and so that people can download it. So our goal is this 4 to 6 train the facilitator classes, certify 80 to 120 facilitators from all the HRIs. Will implement in over 400 classes, reach over 10,000 students per HRI. So just to give you a very quick flavor of the kinds of evaluations we've been doing, and we'll try to obviously replicate that in this. Again, going back to the earlier question somebody asked about can you show what is the value of what you're doing? And I think that is inbuilt in our program, so that we will measure resilience, grit, stigma, mental health literacy, help seeking, and PHQ-9 GAD-7, and rating of irritability, because that's been associated with onset of depression, suicidality, and depressive symptoms. So the plan is we'll have a pre-evaluation completed on the day before, first day, have the 5 sessions, and then a post-evaluation. We, at least in the meantime, waiting for between when we got the word that we are going to do it, and now we've engaged with the local schools just to make sure we prepare and do all this. We've reached about 22,000 students here in this last term. And these are the areas, schools where we have gone to in this year. And a very quick flavor of what we are finding. So here you can see that this is satisfaction with the program. I believe the YAM program added to my understanding of mental health. Very few of them said not at all, thankfully. The YAM program gave me knowledge and skills I can use. Again, very few said not at all. Perception at the end of the program, most of them found it helpful. Half of them found it helpful. The others at least were neutral or didn't complain. The first question, the YAM instructor was skilled at presenting topics. Again, most of them at least agreed with that. Mental health literacy is where we begin to see real differences. I have a clear understanding of what may cause mental health problems. If you look at completely agree, there's a significant jump on both the questions for mental health literacy. Here again, I know that there are several ways to treat mental health problems. Again, we want to be really helpful to the students so that they can then take this back to either their families, the counselors, teachers, etc., when in need. Finally, help-seeking behavior also increases with this. And what we found, actually, we've worked with individual schools and their counselors, that while the help-seeking behavior increases, meaning they go to counselors more, There was some places we were wondering if that means that people will run into bottlenecks. And what we find from counselors and school leadership is that the schools actually feel like this is done now more thoughtfully, so they don't get kids who are really suddenly in an urgent care need, but they get actually a much more orderly referral system because now the students are more informed. So I think we've been publishing the results from these data already, and hopefully when we really launch in the big system, we will really be able to get much larger, clear evidence of what we are doing. And to go back to Octavio's point, I think we are covering a very wide swath of the state, so hopefully will ensure that we will get diverse populations also. In order to get this going again, we have been doing this train the facilitator model. Each trainee that comes here gets a 4.5-day training program. And this is, so to speak, a general schedule of that. Think of it as what actually the students would get in the 5 sessions. But here, the trainers first really become one classroom. And our master trainers then train them and put them through the process. Then the trainees do the class themselves. It's sort of more to get them to practice even before they leave. These are training program sessions we've already conducted in order to be prepared for it. And that has led us to now having 4 master trainers certified by the developers, so that we can then now provide training whenever we need. And our goal is, our hope is, and we've been talking to all the HRI leads as soon as they have staff, and our hope is that there will be enough time between now and when we need to, so that we are going to have the first training session for the HRIs early July, in order for them to be able to hit the ground running when the fall's term begins for all the school districts. There will be ongoing consultation and quality assurance with the facilitators that will go to the schools. And we have a data capture system in place already from all our previous work that will then get the program evaluation data from all the students. We have QR codes that students can basically sign on to and provide all the ratings we just showed you. So I'm going to stop here and open up for any questions.
Okay, are there any questions from any of the executive committee members?
This is Sonia. I have a question. Dr. Trivedi, I was very impressed with the publications or the handouts that you all are going to use. Really, really helpful information to leave with the schools. I was curious about kind of what the expectation will be in terms of numbers that you expect to train on an annual basis. And also I was curious, I know you said that you guys are still in the implementation phases. I'm curious if you have already begun connecting with some of the school districts, and what has the reception been like so far?
So thanks, Sonia. I mean, the short answer is yes, we have been, and that is actually the work we did this this spring and early summer here in the North Texas area, because as you know, all the HRIs had not yet received the funding, so they were not yet ready. But we ourselves went to several school districts, and that is where we got significant interest in that. About 2,000 students were given the YAM program in our North Texas area from our own staff. I think that the issue is that most school districts really, that it happens in sort of steps. So first they're all interested. Then you really have to make sure that there is a very thoughtful engagement process so that all the stakeholders are brought along. The leadership often is very ready to do it, but then you have to bring along the rest of the stakeholders. And if you do that, then I think there is no real hesitation. But if you only involve counselors, but not the teachers or not the parents, then it becomes a little harder. I don't know if that answers your question, Sonia.
So one question I had was the numbers that you expect to serve or train. How many students do you expect to train on an annual basis once all the contracts are executed and everything is fully functional?
So we are, Lachelle and Luann and I are working with each of the HRIs. They have our calculation from what we are doing is we should probably get at least 7,000 to 10,000 students per HRI.
Okay. Or on an annual basis.
Yeah.
Okay. Thank you.
Any other questions for Dr. Trivedi? All right. Hearing none, Laura, we're going to go to you, and you have quite a bit of the last part of this agenda, Laura. I hope you are ready to go. So first, the update on the Family Intervention and Suicide Prevention Initiative under ARPA that you're standing up.
Sure. So we did have everything in our slide deck for Kosh, but we could certainly talk a little bit out of order. This one will be pretty straightforward. The FISP program is, to just kind of level set for everybody, this is a pilot. It's not meant to be as ambitious as the YAM program that's already been well vetted and has research and says, you know, to go forth and do this. We're taking an evidence-based SAMHSA program called FISP that is for emergency rooms, and we are having that team that created it do an adaptation so that it can be useful for primary care physicians in their own offices. And then that's what we're going to train selected primary care physicians in Texas to utilize that ability to create a safety plan when a young person comes into their office having suicidal ideations, thoughts, or behaviors. So we're going to start with 5 teams across Texas. The creators of FISP are going to adapt. They're going to then train our team members at the HRIs that are participating. They will also do the training specifically to the primary care physicians with us participating so that we can, at the end of it, have our own train the trainer so that if this becomes successful, we'll be able to do as Dr. Trivedi is doing with YAM and move out on a larger scale. We will be providing assistance to the primary care physicians for them to come and do the training. And then also when they complete the measures after they've done, hopefully a FISP with the family, they can give us some information back about what their experience was using that tool with the family in their primary care office. So that is what FISP is for those of you who were not remembering from the last time. We've had 2 meetings since the last time we've met, lots of email conversations back and forth. We're anticipating hopefully an ability to potentially connect with the September Suicide Awareness Month of 2022, where we could at that point perhaps be sharing with primary care physicians who might want to get involved in this initial pilot that it's available, and then set up the trainings, and then hopefully start doing some trainings. Not that we'll have every primary care doctor trained in the fall, but start doing some of the trainings with some of those primary care practices that want to learn how to use appropriate safety planning processes in their clinics. And then again, as we get that rolled out, rinse and repeat as we need to. We're actually very modest in this sort of initial pilot. We're only hoping to initially train each of the 2 years, 50 providers across the 5 programs. So again, the idea is to really make sure that this adaptation that they're making from emergency room care to primary care will work well. And if the information shows that it is, then that'll be something that we can start to potentially roll out more beyond just the HRIs that were initially going to do the FISP program. Questions about FISP? Was there another one that I was supposed to talk about too right now, Dr.?
Why don't we go directly into the update on Kosh, and then you can roll in the update on CPAN and TChat as part of the next part of the agenda.
Okay, we will do that. So Thank you, Edith, for pulling up the slides that we're getting ready to wander traverse through. So it was Mother's Day this month, and I thought this was actually hilarious. So if those of you who've not seen this little cartoons, I would encourage you to read them. It's pretty funny. Next slide. So in this brief, I don't think it'll take us more than 30 minutes. Honestly, I shouldn't say that because then maybe it'll take longer, but Dr. Lakey, we will sort of briefly talk about COSH updates. We'll move actually to data governance, and then we will talk through data related to CPAN and TChat. Next slide. So I do want to congratulate Brittany for picking us the other way around. Congratulate us for finding Brittany Columbus, who comes to us with a wealth of experience in kind of helping with program support. She is helping support the COSH team, and what her role will be is to help organize our meetings. We're now going to have the ability to have minutes for each of our 30-minute meetings that we have with each of the 24 teams, that we'll be able to sort of make sure that we're all staying on the same page and keep making progress moving forward. So she'll be doing the organization of the meetings, organization of the minutes, and then a whole host of other just activities that we need to help organize ourselves. So we're just excited for Brittany to be, she's now been with us about a month, so of course she knows everything, and she's fabulous. The next slide, I'm actually going to hand over to Drs. Pliska and Vo. The Data Governance Committee has had several notable items over the last couple months, I guess, since we've met last. So Dr. Pliska, Dr. Vo.
Great. Alex, do you want me to start out? I guess I will. Okay. So some of these are this is some serious stuff here. You say definition of a referral. What's that about? A referral is a referral. Well, no, not necessarily. So in TChat, we started out, as I mentioned earlier, with a fair degree of decentralization. And HRIs chose a variety of methods of accepting referrals based on the logistics, politics, organizational structures that they have. And there's kind of two broad extremes. One is you just say to the schools, send me what you got. So the school counselors are faxing in, or whatever method they have, referrals that basically, of course, they get permission from the parent. Would you like to have someone from TChat talk to you? Yes, I would. Sign release. Okay. Name, child's name, parent's name, phone number goes there. HRI calls and begins to try to get them enveloped, get them into the program. So with that, there's going to be a large number of people you can't get a hold of who say, well, no, now I've thought it over, I don't want it. So you get a lot of referrals to a relatively smaller number of enrollments. In contrast, at the other extreme, HRIs had relationships with school districts where they essentially delegated the recruitment process to the school. So the school counselor would talk to the family, enroll them, maybe even have them sign the consent forms for the program, such that when the information went to the HRI, they were essentially already enrolled. So that HRI would could have essentially zero referrals because everything's an enrollment. And then there can be all kinds of variations in between. As a result, when we began to look in trait as to the number of people who'd been referred, the numbers were all over the map and had no relationship to the size of the program. Or some HRIs didn't know how many people had been referred to them because the schools had done that screening and the schools either didn't keep track or didn't have that information. So the decision the Data Management Committee made was that we certainly will try to keep track of this number of referrals as much as possible, but we're not going to report it as a hard metric. What we will report as a hard number is enrollment, which means the parent, there has been contact with the parent. The HRI has spoken with the parent and has obtained written consent for the person to be in the child to be in the program, and thus an initial appointment could be made. Now there's some additional, obviously the family has to make the appointment, and then there's the question, do they show up for that appointment? But at least defining enrollment as the parent has signed consent gives us a hard number that we can look at across HRIs. And then we can also, that will make sense when we look at it in terms of the size of the program, the number of people in the region, and so forth. Now, admittedly, what this will cause some difficulties with, if we want to really know, well, how many people did the schools refer? We don't have a way of knowing that. Now, that's a question for the executive committee, or the executive committee could task the data management committee with saying, hey, no, that's not good enough, figure out a way to do it. But if we do that, that involves going to individual HRIs and asking them to change procedures that they already have in place. But I think for this initial 2 years of the program, looking at the number of people enrolled will give us very good information. And then we'll also be able to proceed from that as to how many people are enrolled, then make their first appointment, complete a encounter, a complete 4 set of initial sessions, how many people go on to extended sessions, what were their diagnoses. All of that critical demographic and clinical data we'll be able to do on the large set of enrolled patients. Revision of the 5-minute callback metric. Sorry, Laurel, my memory fails me here. Can you remind me of this one?
Sure. Do you want to have a conversation about each one separately, or you just want to talk?
Let me go through them, and then I'll see if people have specific questions about them overall.
So one of the things that we initially had in the CPAN work group was the idea that we would track if a provider for CPAN called and left a message, that we would get back with them in 5 minutes. We've discovered that this particular metric is perhaps not really that beneficial in determining program effectiveness. And it's also particularly difficult to actually track.
So you say
that's what it was.
revision.
It was about CPAN.
Yes, right, CPAN, but remind me what the revision was.
Oh, we were just going to be asking for it to stop being a metric. We weren't going to revise it to something else. We were going to have it just.
And what will be our metric for responsiveness to the pediatrician?
We're working with Lantana right now with the HRI teams with their input as well. Are there other items that would make more sense when it comes to looking at responsiveness? So there's a possibility that Lantana could build a very specific report. There's been conversations, but we've not landed on anything yet.
Okay. And then finally, there was.
Hey, can I comment?
Yeah,
can I comment on the show?
Yeah, please do.
Yeah. So Sandy, we're going to need to talk about that, because I think from a legislative perspective, this is a big deal with how we sold this program. And when we sat there, we talked about responsiveness. So, I think there's clinical realities, but there's also sort of what did the taxpayers of Texas invest in? And one of the things they invested in was fast response to the needs of pediatricians. So I think this requires discussion. This is not something where I would be comfortable with the vendor giving us some sort of feedback on what we should do, because this is a pretty high priority metric.
Yeah, and Laurel, maybe you could, again, I'm sorry, this one particular item, I don't recall the details. How were we tracking it? And how was that problematic? Can you elaborate on that?
So right now, because a provider leaves a message in the Lantana system, we don't collect that data. We don't keep voicemails on just forever. So we can, so you can't track to go back and look, because we've not been asked to keep voicemails. We can look to see if a call went out within 5 minutes of a message being left, but because a lot of times we'll call back with a different number, like the provider may leave a message and say, hey, can you call me back actually in 15 minutes, not right away, or can you call me on a different number, so that when our team calls out, we're actually calling out on a different number now. So you can't see in Lantana that a message was left on this line and then 5 minutes later a message went out to that same number. So there's a lot of manual tracking that would have to be done to consistently say across all 12 HRIs that we can say that yes, this person who definitely, because we're not keeping the message, was it a spam call? Was it, I want to speak to somebody, but not right now, I want to speak to them in a half hour. Because we're not keeping that, that's one piece of it. And the other piece of it, as we call out, we might call to a different number. So you can't just see on the Lantana line that it was actually in response to that call that was left.
But
We do
right
actually,
now, yeah,
but we do,
right now,
Dr. Keller, we do track calling back within 30 minutes. And that's the metric that we're not changing. So if a provider says, I want to speak to somebody within 30 minutes, that is the 30-minute callback metric. And that's, so they're different things.
Okay, that's a good point. Now, just remind us, maybe you can remind also executive committee members, a primary care doctor dials the number, it picks up and they press for their region. That goes directly to the region, or do you have a central hub that picks up first and then directs it to the region?
No, as long as they know which region to call, they'll leave a message out there.
So if it's for San Antonio, our team picks up.
Yes.
And what you're saying then is the moment they pick up the phone, there isn't a way to start a clock that says if they take the call, they just take the call from the pediatrician, then it's 0 minutes callback. They get directly connected.
Yeah.
What you're saying is that if say both the people we have hired are on the phone, it goes into our voicemail. And then that's the point at which if something's sitting in the voicemail, we don't know. We assume our people will hang up. They're checking their voicemail every few minutes and immediately calling back. We don't have a mechanism for tracking that. Do I understand that correctly?
So when you're working the phone lines, if a message is left, you can see that the message has been left. But what you cannot see right now is later, unless we were to start saving voicemails, which we're not currently doing, we're not saving voicemails, then you would just see that a call was left. And then you might see on the Lantana dashboard that a call went out 5 minutes later. But if that call is going to a different phone number, you can't just see at Lantana's level that was in response to that voice message that was left.
Right.
So it becomes very manualized in order to track if that, for the 5-minute callback. Dr. Lakey?
First, thank you for bringing these to our attention. I think probably what we need to do today is, it sounds to me like there may be a little bit of confusion related to how we're going to present this and talk about it. And the 5-minute call, 30-minute call, again, as Andy has noted, we want to make sure that whatever we do, that we can ensure the legislature that we are very effective and efficient in getting these calls back. And the devil's in the details related to how we're measuring this. And so I would say for today, that metric, let's table that for passing any changes and put on paper exactly what the change is. And let's distribute that beforehand to the whole executive committee, so we are all on the same page on exactly what the change would be, what the implications of that change would be, and how we can make sure there aren't any unintended consequences related to what that change would how it would impact.
In fact, I'd take it back. I think the governance committee has to look at it again and dig a little deeper. So why don't we take it, not only put it on the table, we'll take it back to the committee.
That'd be good. And then
one point on that, because we are talking about calls that go to voicemail, right? That's where this becomes an issue. We can assume 80-90% of the time our people are just picking up, say, hi, Dr. Jones, and proceeding. Now, there is a separate issue when they connect to this child psychiatrist. Again, the child psychiatrist should be sitting there ready to take the call. We do know that occasionally, like he might be on a call with the prior call in or something, there'll be a gap there, but going into voicemail should be relatively rare. But it sounds like we don't have a way to even track that. What percent of calls go to voicemail?
We do. Yeah. So the Lantana, yes, you can see how many calls ended in a voicemail. It's actually extremely small right now.
Great.
But what we are not currently doing that we may want for people to consider we want to do is we're not currently saving the voicemails. So you can't necessarily say, because you can't look at the Lantana and go, this voicemail was a robocall, because we get those sometimes. Or this voicemail really was a provider wanting a call back. And then if that provider says, I want you to call me back at a different number, you cannot see that in Lantana. That is a manual process.
Okay.
But yes, we can't do it.
All right. Okay. That's exactly the kind of issue I think the data committee needs to dig into a little bit more and come up with, first of all, to define the problem very clearly for everybody, and then we can look at options. So let's table that one. Let me discuss the last one. It too, I don't think will be that controversial. So this concerns not any particular metric, but the trait portal that we are developing for teachers to put consults in. And in the original version, there was a checkbox would just say that it was urgent or needed a same day appointment. And virtually all of the HRIs found this problematic because it might be a school person just checking that when we would want them to communicate with us directly if it was indeed urgent. So the urgency should be determined by the HRI's review of the consult and the communication with the school. And then we make a decision. Does the person go to the emergency room? Do they come in the next day? Can they, in fact, can wait for 3 days? That's a clinical question that has to be determined on a case-by-case basis, and it shouldn't be reduced to the level of a checkbox on a form. So the data committee recommended that checkbox be removed, and it really won't change any clinical practice because we're looking at our referrals as they come in, and we all have relationships with our counselors in terms of handling urgent situations. Any questions on that? Okay, so from what I'm hearing from the executive, the definition of referral and enrolled versus number, people are okay with that. We've tabled revision. That will go back to data committee for further study. And then finally, people are okay with removing, with the amendment to the trait software to remove that checkbox with the urgent question.
I see a hand by Dr. Trivedi.
Sure, go ahead.
One of the things, at least we found useful, Steve and Laurel, when something like this, where the voicemail thing becomes complicated because you can't organize what they'll say, is that when a phone gets to voicemail, we say, send us an email. That way you can monitor is another option to think about.
I think there's going to be a variety. I think there's a variety of things I think we need to look at a little more deeply.
So any other questions or concerns about basically three, and in many ways it sounds to me like two basic adjustments on how we are monitoring things. One, looking at the enrolled versus the ones that are referred, because the issue of parental consent and all the other things that Steve said to make sure that we're only measuring the ones that we really have the ability to see. And then the second, removal of that urgent consult question. Any concerns on either one of those? Okay.
All right.
So I'm going to do it. I'm going to make it formal. I have a motion from the data committee from Steve Plitzka. Do I have a second?
I move that the executive committee accept the definitions of enrolled versus number, the definition of clarification of the definition of referral and enrolled, and the removal of the urgent question from the trait teacher portal.
Okay.
Second.
I have a second by Dr. Podowitz. Any further discussion? Hearing none, all in favor signify by saying aye.
Aye.
Aye. And David, do you need a formal motion to table the revision one?
No, we can just table that one.
Okay. All right.
Any opposed? Nay. Anybody abstain? So Steve, we have approved those two. So we'll be monitoring enrolled instead of the number referred, and with the removal of that urgent consult But for the 5-minute callback, let's take that back and put on paper exactly what we're thinking and how we'll make sure that we're not losing some of that granularity and the measurement of effectiveness that we need to give the legislature. Okay.
I do want
Good.
to add that, you know, Dr. Williams Kosh, some of her presentation slides actually do have metrics that show time to respond. So we should address somewhere to Andy's question. So
Okay.
you'll see that in a second.
I just think we need to be very clear with what we're doing, and so we just need to work on that a little bit more. All right, Laura, let's go through the rest of this presentation.
Okay. Yes, that's why we come to the EC, so we can hear feedback, and it's very important. I actually will say that I really did appreciate the internal external evaluation team's work. A lot of the things that they've presented to us, both at COSH and at the individual HRI levels, actually has turned into initiatives that we're doing for ARPA. Several of the things that primary care physicians asked for, or school personnel and school teams asked for, both for CPAN and TChat, turned into ARPA initiatives. So I think their early work in helping us learn what people were noticing and valuing about the programs, as well as what they wanted to see more of, we see that that's something that we're able to move forward. So CPAN, the Project Echo, again, a lot of the providers across the state that were surveyed wanted more education in the primary care field around mental health. So our Project Echo, which is actually getting a lot of national attention, is running very well. We're going to start to have a fall spring of the CPAN. So we're going to rinse and repeat for the next couple of years, the fall schedule of didactics and the spring schedule of didactics. The spring one, we're halfway through the 3 of 6 sessions for our Project Echo this spring. We have across the state 357 learners who have attended. I think a slightly larger number who have signed up, but again, primary care doctors are busy, so they can't always show up at them. And then our last Echo presentation for this spring series will end in June, and we'll turn right back around and replan for the fall series that we'll do as well. So we're very excited for that. For the direct consultation, we are for the ARPA project. Again, this was one of the areas in conversations with other teams nationally, as well as the feedback we got from the evaluation teams from primary care, is that they wanted more services. And this is one of those more services. So we have been working with the CPAN leadership team around the content and process of doing a direct consultation within CPAN. We've developed our first attempt of what will be the metrics, what things do we want to be tracking as we start to do this direct consultation. That has been signed off initially by the leadership team. So now it's going to data governance committee, again, to allow for the evaluation teams, as well as the data managers of the governance committee to review those potential data points and metrics for direct consultation. As soon as we get everybody to kind of agree on what those particular metrics will be, then we will put an official change order request into TRAIT for them to build out the call form, what we're calling call form part 3, which is the direct consultation piece. And then we are obviously, everybody's waiting in part to do some of their ARPA projects based on getting their contracts in and getting any additional staff as they might need. So we have an anticipated go live for direct consultation in the fall of 2022. There's not just the TRAIT process that has to get worked out, but also the individual HRI level processes that need to get worked out, as far as training of our team about when to potentially recommend a direct consult, and then also how they're operationally going to proceed to do the services at their HRI. So a couple of more moving parts and moving steps before we can move with that.
I don't think I have much.
Dr. Podowitz, we can hear you. The next one is the texting pilot. We did partner with Texas Pediatric Society. Dr. Tran helped us find a group of primary pediatricians who wanted to help us do our first sort of what we're calling pilot before beta testing. We got a cachet of folks through TPS. It still was kind of slow. We didn't get as many people texting us in requesting help with the consults as we had hoped. So then we did open it up to some of the super users within each of the 12 regions, that they were given special instructions about how to help potentially participate in the pilot. We were hoping to get at least 50 primary care doctors texting, so we could get a small enough group, but also enough, hopefully, variability. And after we hit that 50 mark, then we were going to ask each of those providers to do a very brief survey about how they thought the consultation, how the texting process went, what they liked, what they didn't like about it. And then based on those results, once we get done with that, then we will kind of work again with our teams to do any changes that might be necessary, and then actually go into beta testing for the process. We're about halfway through. We were wanting 50 CPAN calls to be through texting. We have about 25 right now. So we're certainly hoping that we can kind of get a few more out, and then we'll be able to present. Hopefully people will complete the survey, and then we'll kind of present what it is that they're saying we might need to change or improve before we move to beta testing, and then possibly moving on a statewide level. One of the things that Trait will need to do when we move forward with that is in the call form part 1, the documentation of the consultation. We will have one of the very first questions be, how did this consultation come into you? Did it come in via a call, or did it come in via text, so we can track those numbers? And then I already told you about FISP. So she's going to switch over to the dashboard. Speaking of Dr. Vo's sort of comments about data. At least I think that's what she's doing. I'm reading her mind right now. Edith?
Give me 1 second to lock me out.
Uh-huh. So we have protections all the time everywhere, right? You get logged out if you're not in something and staying active in it. So she's unlocking herself out. And Dr. Thompson, your hair's getting longer. That's nice. Maybe you're not meaning to do it on purpose, but nonetheless.
Going back to surfing.
So this is the dashboard. We're just going to review this briefly. It's hopefully familiar to most everybody here. Wanted to remind you the Data Governance Committee, along with the evaluation teams and Luann's team, have speaking back to your question about data for the public, that the very top line of the dashboard is now going to start being updated every month and put on the Texas Child Mental Health Care Consortium website when you go to CPAN. So you'll be able to start to see this very top line. They're working with Melanie's team right now, because again, as you can see here in the dashboard, well, I can't do it because I'm not in the dashboard. I'm a good example. Can you hover over enrolled providers, please? So again, in each of these areas, there's because it's a dashboard, you can actually see some bit more information to provide context. So one of the things that they're doing is sort of creating the dashboard and then putting the context underneath so people understand what they're looking at when they look at the data. But to date, we have over 8,000 providers that are enrolled. This does actually include physicians, NPs, PAs, as well as medical director and residents. Of those 8,000 providers, they're in about 1,500 enrolled clinics across Texas. And to date, since CPAN is open for business, we have 9,579 completed consults, estimating about 8,600 patients served. That's because, again, provider can call in and ask for generic information, not tied to a specific patient, or for other reasons, prefer not to give us patient demographics or information. So that's why those two numbers don't always line up. And to Dr. Keller's point, we did set our baseline goal of calling back within 30 minutes at the 90% mark. Any teams that any trouble and they fall below that mark, we have conversations. But as a statewide, we've been able to respond within a median response time of 6 minutes if a provider across Texas wishes to speak to a child psychiatrist. One of the things we're actually finding providers like from us, they do appreciate the quick callback of 30 minutes, Dr. Keller, but they also like that we will say to them, well, when do you want us to call you back? What actually makes the most sense for you? And then we have the ability in Trait to note that they actually don't want to be called back in 30 minutes because they got 2 more patients to see, but they want us to call them back at 2:30. And so then we can note that and call them back exactly at the time they want on the phone number that they want.
Laurel, how does the start and stop and complete time get into Trait right now? What are your
So the team member asks the provider, do you want to be called back in 30 minutes? If they say, yes, I do want to be called back within 30 minutes, they will note that in trait and the clock starts then. The clock starts ticking. The clock does not stop ticking until the child psychiatrist goes into trait and indicates that they were able to reach that primary care provider. Once they say I was able to reach them, then the clock stops ticking.
There you go. So that is everyone on the committee clear on that? So the clock stops with the child, with either the child psychiatrist or the staff member saying in trait, clicking in trait, we have a connection. And that's how that number is coming up. So that tells us, at least from the time the staff and the pediatric PCP are speaking to when the psychiatrist answers it, the median is 6.1 minutes, except when the PCP specifically says, please call me at a different time.
Correct. This metric is only when that is selected that I want to call back within 30
Yes,
minutes.
and that's entirely appropriate.
Yes, sir. Alrighty. You can see across the state, we've done a very excellent job of getting clinics to enroll. We have just a really small number of clinics that are kind of lingering in their decision point of enrolling in clinics. I want to be mindful to Dr. Keller's point that you don't actually have to enroll in CPAN for us to help you and help you take a call. So a clinic provider can call us, state their provider, and we would still provide them assistance. What we could not do at that point if they're not enrolled is if they call back later and say they want to speak about a very specific patient, we don't allow for that. So, but we can take their calls and we will help them whether or not they're enrolled. But of course, our goal is to try to help enroll them for all the benefits that they get besides just the callback. Again, across the state, we have a mixture of clinic types. This is one of the things you can see a lot of regional variation in when you look at the individual HR levels. Depending on where you are in the state, there might be more family physicians, less pediatricians, more integrated clinics, and those kinds of things. One of the things that we think that helps us with is with that engagement strategy, as engagement strategies may need to adapt or change based on the sort of populace of the type of providers that a CPAN team might be working in. Can you scroll down now, Edith? And so I just want to also point out that we've, for the last 3 months, had an over 800 per month consultation volume. So we're very excited for that. Child mental health is a seasonal process. So there is a good chance that we might see a little bit of dip during the summer months, but we're very excited to see this pretty nice, healthy upward trajectory and then sort of sustainability in that as well. And then when you hover over April's clinic staff engagement, Edith, the next one over. You can see that providers are calling multiple times. In fact, 50.8% have called more than once. And so this is something we're also happy to see. And we think that does lend itself to the information that the evaluation teams have shared, that once a provider tries a service, they find it effective and helpful, and it drives them to call again. So a lot of the work that we're working with Melanie and how she's helping each of our individual teams is really to try to convert that number of those who've not yet called to become a first-time caller so that they can get the benefit for their families and kids that they're treating and serving. And over here to the right, you can see the types of the types of clinic staff that are calling in. The overwhelming majority of them obviously are physicians, but we do have other team members that call in, including nurse practitioners, physician assistants, and sometimes the nurses themselves are maybe helping that primary care doctor get the call started, for lack of a better word. All right. And then I'm going to talk a little bit more detail in a second about some of the purpose and context. So we can go ahead and stop sharing the dashboard, Edith. All right, she's going to switch back. I'm so happy that she's helping me. So I don't have to be anxious. I can just sit here and chat with you and not feel anxious about trying to move back and forth. All right, so this is the purpose of contact. So again, one of the things that we're actually starting to do now a little bit, we don't have any, there's no analysis that's happening right now that we'll need the data governance committee to do that kind of work, but we are just starting to look more specifically at some of the data that we have been collecting. And we wanted to just highlight that of the consults that we're seeing, again, the vast majority of the time, a completed consult does revolve around a specific patient that the primary care physician is calling and asking for help very specifically with a patient that they have in mind and hopefully in office. We've also tried to help providers know that you don't always have to call us when they're office. You can call us when the primary care, when the family has called and left you a message that you're, as a primary care doctor, not sure how to answer, but you could call us as well, even when you don't have a child in office. But nonetheless, they're mostly calling us about specific patients. And is similar to other programs nationally. The vast majority of time, the providers are actually asking for help with referrals and resources. So, about 2/3 of the call are those kinds of assistance and help. I do want to point out that's one of the reasons why the teams are staffed the way they're staffed, that we have more team members who are staffing the phone, Dr. Keller, because that's what they can do. The very first phone call that they get from us could be the person that they pick to answer the phone, might be the person that can actually help them right then. They don't even need a transfer to the physician because that team member is going to be able to understand what the clinical scenario is and then start researching and trying to help them find a resource or referral. Interesting that the providers in the external review were asking for more help with this area. That's one of the things that Melanie did with her work and her research with her team, was that despite our, what we thought was pretty good attempts to tell providers the 3 services that they can get, it didn't seem to sink in as much that actually we would help you find resources and referrals. So I think Melanie's been, her team's been doing an awesome job really helping us put out information to providers across the state that that the CPAN service is actually 3 services in one phone call as needed. And then as you can see here, we continue to have, a small minority of kids that are that they're calling about that there is concern for an emergency. When you look at that data more specifically, the vast majority of those emergency situations involve suicidal or self-injurious behaviors. And so this is one of the reasons why, again, our ARPA FIFS project is about trying to help equip and train primary care physicians to deal with suicidal, self-injurious behaviors and emergencies that are occurring in their clinics. And so we think that's why it's a good fit for an ARPA project. Next slide. When you look to see, again, because 2/3 of our business is trying to help them find referrals. So the process that happens is the provider calls in and says, hey, I have a young person with a particular issue. I think they need this kind of help, or I'm not sure what kind of help they need. Can you help me think through what kind of help they need? Then our team goes and starts to do some digging, do some research. What we actually work to do, Dr. Keller, is within 1 business day, respond back to the request for resources and referrals. Sometimes the resources we can give right then, but going and looking for a referral might take our team a little bit of time to dig. So we're kind of functioning a little bit like a case manager. Our team cuts the information down, the age, insurance status, where the person lives, and then our team goes and looks to see what resources might be actually helpful and available. Our team is expected to actually call these resources, referrals, to make sure they, what is your timeline? What does your wait list look like? So that when we send that information back to the provider, we're giving them actually real-time information that they couldn't have gotten on their own. Now, sometimes we ourselves struggle to find a resource or a referral. And in that case, what we still say is that we will call that provider every business day and give them an update about where we are until we hopefully locate a resource or referral for them. So you can see here just the types of referrals that we're tending to hand out does seem to be largely trying to help them connect with therapists within their local area. A smaller amount trying to help them find resources where they actually are connecting with a child psychiatrist. This is really important. I just going kind of referencing Dr. Wakefield's PeriPan conversation. One of the things that CPAN and PeriPan and these types of programs are trying to do is upskill the primary care physician so that they can provide the evidence-based interventions in their own office so they don't need to be referred to higher levels of care. So really trying to help those primary care physicians make sure that they feel like they are able to assess and make decisions supported by the team so that when applicable, they can help provide that actual intervention in a primary care office and not have to go find a resource or referral. So that's, again, that ongoing process that we hope to continue to do within our CPAN and eventually the PeriPan program as well. Next slide. One of the things that we did want to look at that we've not shared with you previously is we wanted to look at what were the top 10 diagnoses that primary care physicians are calling us on, speaking to that issue around education and support, what kind of CME activities we want to build out for providers across the state. I'm pleased to say this is very in line with our ECHO project, by the way. We did actually work with TPS and others about which are the top issues that primary care doctors are struggling with. But it's, I guess, a little bit confirming to see that our ECHO and a lot of our CMAs really align with the types of diagnosis they're calling in and asking for assistance. Now, this is not the total number of overall calls. As you saw earlier, it was about 8,000 were about specific patients. That's because a primary care doctor could call in and say, well, I don't know what the diagnosis is yet. I potentially am having issues with these types of challenges or behaviors. So it's only if the primary care doctor calls in and says, I have a very specific diagnosis, I'm pretty certain that this person has anxiety disorder, that then our team would put down that the primary care doctor is saying that they're dealing with a particular anxiety disorder. So we actually have these down very nitty gritty. Trait has loaded the DSM-5 into Trait, so we can very specifically look at major depression, depression secondary to medical condition, all the various ways that somebody could possibly say that a person is depressed, as well as some of these other disorders. So what we did here is we just condensed all those that were about depression into one larger one. So you can see here that the top 3 diagnoses that they call about are depression, ADHD, and anxiety, and then sort of falling right after that is young people with autism spectrum disorders. So we thought this would just be important and interest for team members to see that sort of what types of diagnosis do primary care doctors seem to call us about. And to Dr. Wakefield's point earlier, we may see over time that they start to call us about DMDD, bipolar, perhaps even there was so few psychosis that it didn't warrant it being in the top 10. But that as they maybe get better equipped at managing mild to moderate ADHD, anxiety, depression, then perhaps, as Dr. Wakefield suggested, we'll start to see the type of psychiatric complexity increase as we're helping them and supporting them with the diagnosis that they call in about. T-chat. So one thing we do want to talk about in regards to the conversation that Dr. Pliska just had with you around the differences between what a referral is and what an enrollment is, the data that we're sharing right now with you is just preliminary. It is about children who've been enrolled in the service. So these are families who have consented to care. And so that's what we want to make sure they're really clear about. So the number of enrolled patients across this academic year, starting in August of 2021, you can see here each month the number of enrolled students, in my opinion, patients by that point. They've moved from being a student to being a patient within the HRI's TCHAT clinical program. You can see this follows a very seasonal pattern that is very familiar to us in child mental health, that you see that peak happening around the October timeframe in the fall, and then you see another peak again for young people in that February, March timeframe before potentially you start to see some declines as you move into the summer months. So this is the number of enrolled patients that is provisional for TCHAT this year. Sessions. So this is also something that we want to make sure really people are very clear on. There is the TCHAT service is meant to be thereabouts 5 encounters for a general average TCHAT episode of care. A session one encounter can actually have more than one session, although that is actually less common than not. But that is if, let's say, a psychiatrist sees a patient on the same day that the therapist sees the patient, that is counted as one encounter, but it may be 2 sessions. So what you see here is the total number of sessions. This is the total number of direct care that TCHAT teams have provided across the state since August of 2021. And you can see here sort of that total number of 22,705 as of the end of April. This is a different sort of slice. We're looking at the young people that potentially are either completely done with their service, and that's what complete is. Those are young people that have been archived, their episode of care for TCHAT has been completed. That is the 1320 number that you're seeing down there. The next three numbers that are a bit smaller are actually youth that are in what we call a transitional state in TChat, where they have potentially been moved into, they're ending their services, but they've not been archived yet. And you can see here that they could either not yet, the team has not designated why they've moved into end of care. Sometimes families, for whatever reason, may drop off and the team members might be trying to reach back out to them. And so they might not be ready to actually archive the care. So that's where you might see that the unknown is, that's what our largest percentage is probably there. And then you do then have some young people whose families said, I've declined, I'm kind of done with services. And then you have some where they've actually, we know for a fact that they've no-showed for an appointment. So there's a little bit of movement that's going to happen here, which is why we say this data is preliminary. And we do anticipate in the summer that this data will become kind of put into the bucket of either they're active or they have been completed. So when you look at that total count that we showed you with the slides at the beginning of the TChat, is that we had 7,451 young people to date who've enrolled in TChat services. Dr. Pliska's point, not all of those enrolled patients have actually had a service, but they have consented to care. You see about a third of them are still in active treatment, getting TChat services. A third of them have been archived. That means that their services have been completed. And then about a third of them are in that transitional state where it's possible that they might be done, but it's also possible that they have maybe been lost to follow-up. So we expect to see, particularly for that transitional state, some changes and movements to that as we move into the summer. Next slide. Done. I think it was 30 minutes, Dr. Lakey. Let's try it. Dr. Lakey, we can't hear you.
You're still muted.
He's working on it. Maybe. I think they're all in the same room together, so they're trying not to have feedback.
Sorry, can you hear me now?
Yes.
All right, our room was muted, which is just the way that it's working. So quick question on CPAN, on medications. We had talked about earlier of trying to get more granular related to what it means related to medications and whether it was medications started, medications changed, medications stopped. Do you think we're going to be able to get that kind of granularity in the near future, or is that still a ways off?
We're working on it right now. I think that we'll have some level of granularity in the somewhat near future, Dr. Lakey.
Okay.
So yes, but we don't have it ready yet.
Okay. Other questions?
Laurel?
Yes.
You did it. This isn't about your presentation, rather, I wanted to just bring out an issue that was discussed much earlier on from the evaluation teams, which
Sure.
is that some of the feedback from the school folks suggested that they have the belief that they're, in a certain sense, I wouldn't say entitled, but that they're expecting kind of this ongoing feedback. And is that something that we need to address? We don't want to be disappointed. I don't want to overstate the nature of the issue either, considering that it was just anecdotal data, but being mindful that that is our referral source.
So that's a good point. Thank you for bringing that up, Dr. Blader. So we are working with the TChat leadership team around a school portal. We have discussed what is it that we can share to a school that would not be TMI or too much information. Again, we have to realize that families have to consent for us to collaborate. So there's certainly a fair amount of information that we cannot and would not share to a school unless the family gives us that consent. But as far as the number of referrals in aggregate, the number of students that maybe have gotten the service, number of declined in aggregate, the school portal is going to start to address that. So the school portal will be designed as a permission-based process, so that an individual counselor could see in aggregate how many referrals they've made and how many of those referrals have turned into care and how many have not. And then that'll always roll up to each permission level, so that a school district that maybe has several schools that are working in TChat, they could see not just the individual counselor, but sort of in aggregate how the overall school is doing. So that's one of the functions that we'll have with the school portal. We'll also be able to, with the school portal, more easily transmit the sort of some of the paperwork that they would need. So that was the other thing that schools had mentioned was a pain point for them for TChat. So we're going to have a document upload feature in the school portal that will allow for information to come in a HIPAA compliant manner to us as needed. Again, everything flows with parental permission. So when it comes to providing more specific information about a young person, that has to always be driven by the parent or legal guardian giving consent.
Yeah. So point being, whether that needs to be clarified with some of the schools.
I think that, again, most of the teams are planning to use the school portal. I think 11 of the 12 teams are going to introduce the school portal to all the schools that they're working with in the summer, and those schools will start to utilize it. And then they will, as the school year starts, they'll be able to start to see that aggregate level data.
Oh, well, the utilization data is that's one thing, but to the extent that people want to know, well, did they really talk about what happened when the 30-year-old sister came home with her baby and caused now that everything's gone, off the rails and that kind of thing. That's what I think they need some education.
No, I don't disagree. I think that's a good point for us to bring back to leadership teams, that how we're making sure the schools really understand those distinctions. It certainly has been a problem, and outside of just TChat, whenever you do some school facing clinical services, sometimes the schools are a little bit confused about what it is that they have access to and what they don't have access to. So it's always a good teaching point.
And to my memory, it's really not all that much different from school psychologists who were doing treatment in schools. They just can't just blather on about what happened to their colleagues. So it shouldn't come as a great surprise that an outside provider would basically have the same kind of boundaries. So
I agree, but I do think it's worthy, like you said, of making sure that our HRIs are really sharing that. Some of it may also happen as as schools start to get new counselors and people turn over, they don't always know this information. So kind of annual trainings and reviews for schools about TChat probably makes a lot of good sense. And I think a lot of teams are doing that, by the way.
Yeah, great. All right, thanks, Laura.
Any other questions? Hearing none, thank you, Laura, as always, for the great update. Let's go to Steve Plitzka. Dr. Plitzka, you want to give an update on CPWE?
Sure, I'll be very brief. And first, I must thank Lachelle for making this excellent Power BI presentation on the CPWE data. Actually, I've been using Power BI myself for doing clinical reports within the department, and it's a really excellent platform for displaying this kind of data. What you see here is a list of all the HRIs that have various partnerships. We right now have 17 which are with LMHAs and 4 which are in a community. I believe Metro Care Services is one of these, is some strange entity that either is or is not an LMHA. We're not really sure. Maybe the Dallas people would like to expand on it. But at any rate, for right now, we're considering them community because they're not coming through the HHSC LMHA feed.
So Dr. Plitzka, this is Danette. I'd be happy to explain that. So
Please do.
Yes, this would be easy. Metro Care Services is a statutorily authorized community mental health center in the state of Texas. It does not also serve as the designated local mental health authority. It is the only one in the state that does not also serve as a local mental health authority. In the Dallas area, the North Texas Behavioral Health Authority does fulfill that authority function in contract with the state, but Metro Care is still a statutorily authorized community mental health center. They are a public entity and one of our members.
Very good. All right. So, and then, so now, in terms of the looking at general in a very preliminary way, these are the number of encounters at the LMHAs by month that are reporting through HHS. So this would exclude anyone seen at El Paso Child Guidance or Metro Care or any of the community partners. Those HRIs are reporting that data manually to David Lynch, and ultimately we will integrate that into this report. But here we see the growth in the number of clients seen. You want to ignore the April findings. That's at the time this report was done, it's only partial data. So next month, of course, we'll have, yes. Mhm.
This is Luann, and if you'll look to the top left-hand corner under age group.
Right, I just got, thank you, just got the child. So I pull that off, it jumps up. You can see now this includes the adults. And if we want to, well, there we are. And then if we just want to look at the adults, we see just the adults. We might, Lachelle, we might think about a way to split these columns so we could have child and adult within each one. It might be a little easier to look at, but nonetheless, it gives you a good idea of that we're getting steady growth. You can see the division by the various HRIs, which reflects the number of residents, the size of the program that they bought into initially. We don't have data looking at, clients seen per FTE or anything of that sort at this point. Actually, if I look over here, here we are, child versus adult. It's already here. So this shows the comparison. As planned, it's a predominantly child-focused program, but we are serving adults as well. Any questions? Very good. That's all I have.
Hand still up, or do you have another question, or was that from earlier?
Danette, you have your hand up?
Oh, that's from earlier. I'm sorry.
Okay, all right, very good. All right.
Dr. Pliska?
Yes.
This is Luann again, and I just want to make a point that this is not complete. Not all HRIs have reported yet.
Right, correct. We don't have any of the non-LMHA data in here at this point. We will have that in the future.
And I think there's a few HRIs that also don't have some LMHA data coming.
Well, that could be true too. The people who have just signed up, we're getting that process going.
Yeah, I just wanted to add as well that Burke is not listed in one of the sites, the community sites as well.
And you have people actively seeing patients as we speak?
Yes.
Okay, well, you get with Rishi Swanee about getting that rectified.
Thank you so much.
All right, any other questions? So I think it'd be good for all HRIs to take a look at the data, make sure the data that we're getting is correct. And Steve, again, appreciate, I've seen quite a few of your emails and following up with folks, making sure we get this data as accurate as possible, and appreciate all the work to do that.
Yeah, fortunately, all the data we need to put in here will just make the numbers look better.
Yeah. Yeah. And even with that, we're, soon approaching 10,000 individuals, right? We're about
correct.
So
Correct.
if there's others in, we're going to be even closer. That's good. All right. Steve, while you're still there, and before we wind up this meeting, you sent me some information earlier related to one of your colleagues that a lot of folks here probably know about, and wanted you to give you the virtual podium just to share with folks some of those things you shared earlier today.
Okay, sure. I wanted to kind of bring up the fact that last month, Charles Bowden passed away, and he was a good colleague and mentor for many of the people on the committee. Just looking here at the screen, I see, see Jair, Peter, Duder, and many more. I know Octavio, you knew him well, and Karen Wagner as well. Charles Bowden was, he's native Texan. He graduated from UT Austin with a chemical engineering degree, went to med school here in Texas, I believe at Baylor, and then did his residency at Columbia and returned to Texas. Really was at the forefront of research in psychiatry over the last 50 years. He worked with Jim Moss, doing a lot of the fundamental work on the monoamine theory of affective disorders. So when we talk about, everybody reads Steve Stahl's book about serotonin reuptake and dopamine blocking and all of that. Well, it really was Charlie's generation of psychiatrists that really helped us with that understanding. Charles Nemiroff was a big part of that. And then of particular impact, Charles really led the study of Depakote in the treatment of bipolar disorder, which is now perhaps one of the most widely used medications for bipolar. So he really kind of expanded the range of treatment for people with severe mental illness. And Charlie was a very, in many ways, very quiet and modest man. I don't think his reputation was as well known, outside his colleagues as perhaps it might have been. And that, of course, never bothered him. Charlie was just happy doing his work and supporting his colleagues. So Charlie retired, and he sadly did develop Lewy body dementia, but in the final years of his life, he really dealt with that with enormous grace. And in fact, I had a kind of, when he was really struggling, he was still, set up a meeting with me in order to donate money to the Department of Psychiatry to kind of support research going forward. So I wanted to mention that to all the members, and what I'd like to do is for the next meeting is kind of bring forward a formal resolution that kind of summarize all of the things that I've just said. And I think it would be a great tribute to Charlie, as that so many of us knew him, that if we as a body could pass a formal resolution and maybe send that to his family. Sadly, his wife, Virginia Bowden, died just recently, 2 months after he passed away. And she too was a woman ahead of her time. She was a computer programmer in the 60s, one of the original that programmed IBM mainframes. And then she went on to become the director of the Briscoe Library here. So it's really the loss of two people that really contributed very much to the UT Health Science Center at San Antonio in particular, but also to the UT system and to the state of Texas in general.
Thanks, Steve.
All right. Yeah, Charlie was a great role model, very influential in my career and the career of many others. So he will really be missed. Thanks for saying what you said, Steve.
I would add, Steve, that they were also great benefactors to a number of cultural institutions in our area and social causes.
Very good. Well, thanks, Steve, again for bringing that up. So we have just a little bit of time. Any items that the group would like to share related to the current work? All right, I'm not seeing any hands raised. With that, I think, Luann, are we done with the items on the agenda? Anything else we need to vote on, or?
We're done.
All right. So again, thank you all for your time and your commitment to this initiative. A lot of follow-up related to moving these initiatives forward, and look forward to seeing what we've talked about today moving forward. Again, a lot of activity with again with the ARPA funds and our previous work. So again, thank you all, and we'll see you soon.
Thank you.
Thank you. Bye.